this guy. So the next one is, and yeah, the hybridization process is totally reversible. Yes, your cardiomyocyte will be immotile, but after the putting back of the blood to the cell, which is the reperfusion, happens, the cell will become functional again. So when they become functional again, they can contract again. If they contract again, you have gain of function again. So it's totally reversible. The last thing you have to know that in case of neuronal damage, there will be aggregation of peroxidized lipid within the myelin sheaths of the nerve cells, and I will show you this in the future. Okay, so let's take a look at this graph here. So the normal cell here, it has a lot of organelles inside. This is the mitochondria. Please know that the electron transport chain and the oxidation process of our body happens here, the internal respiration basically. This is what? The rough endoplasmatic reticulum. What these little organelles on it? Correct, it's the ribosomes. Good, and these are the lysosomes here. So, lysosomes are the trash can of the cells. Rough endoplasmatic reticulum is your factory which makes you the proteins. The mitochondria is the place where you make energy, the nucleic material, and this is the nucleolus. By the way, just a fun historical fact, a nucleolus means the room of the king. So it's the middle of the middle. But for the USMLE, that's not important. What is important though, that you know that all of the ribosomes, see these ribosomes? All of the ribosomes create all of the proteins in your body. But ribosomes in themselves have the proteins inside of them. Maybe you remember this S's, the 40S and the 80S and all of that stuff. So these proteins, which makes the ribosome themselves, where did they come from? What made them? Well, that's your answer. It is the rRNA which comes from the nucleolus. This is a USMLE question. Please know that. It's not in first aid. Okay. The next idea, so we take a look here, reversible injury. What happened? Swelling of the cells. We said after like the dysfunction of the sodium-potassium channels, we have a lot of sodium accumulating inside of the cell. So since we have a lot of sodium accumulating inside of the cells, this is super serious. The cell will have more sodium inside. It will attract water from the outside to the inside. That will lead to swelling of the cell. Well, that water, of course, will go inside of the cell. So that will lead to the swelling of the cell. It will go inside of the rough endoplasmatic reticulum. So it will lead to swelling of the rough endoplasmatic reticulum. And you can imagine if this is really swelled, what will happen? These little ribosomes will just detach. Boom, they just went out. Okay, so the next thing is the mitochondria. For the mitochondria, it will also be swelled, so they will also intake sodium inside, and that will make it enlarged. If you look at the wall, you can see this membrane blobbing. The membrane blobbing is due to overaccumulation of water inside. When you see that, that does not mean the cell is dead yet. And take a last look at the last thing, nuclear chromatin clumping. So if you take a look at the chromatin here, it was all over the place. But here, it just started making groups. But these groups, if you enlarge on them, you can see that they are normal shaped overall. But if it becomes irreversible, stuff changes. Well, I want you to know one word. For reversible injury, it's a swelling. Okay? Reversible injury of the cell, it's a swelling. But if we say irreversible injury, we say tearing. Tearing, swelling. Swelling, tearing. So let's speak about tearing. So it's a breakdown of the plasma membrane. If the plasma membrane breaks, what will happen? Your cytosolic enzymes, like the troponin in case of the heart, will leak outside. And there will be influx of calcium, which lead to activation of degregative enzymes. Let me explain this a little bit. In case of the heart, you know, someone had a heart attack. Come on, do an ECG on him. We did the ECG. We saw the ST segment elevation, all of that stuff that we'll explain later. But you are not sure if he have a heart attack or not, or you want to confirm. What do? You check, we keep saying, we check the cardiac enzymes. What are the cardiac enzyme? The troponin and the CKB. So you are like, okay, so what are these enzymes? Well, these enzymes are basically enzymes that are located inside of the cytosol. So if the patient have ischemia, the cell will have less perfusion. Cell have less perfusion, it will have reversible injury, and then it will have irreversible injury. If it has irreversible injury, you can imagine that in cases of irreversible injury, the cell is dead, and when it dies, it will secrete markers like troponin. So the marker such as troponin in this case will tell you that the cell has completely died and this is irreversible, and this is specific for heart attacks. Please keep in mind that the troponin does not get high immediately. As we said, it takes time, and since it takes time, well, it takes time, it does not happen immediately. So I hope it makes sense. So the gold standard for checking MIs are not the troponin initially, it's ECG. Okay, so the cell has broke. The membrane is exposed. There is holes in the membrane. So what will happen? There will be influx of the calcium. So the calcium will come from the outside of the cell to the inside of the cell. Okay, so what is the big of a deal? Like calcium came inside. Well, calcium has a dear friend to his heart. That friend is called caspase. And when that caspase gets activated, he just becomes crazy. He starts destroying everything around him. So caspase is a degradative enzyme. Also hydrolase is a degradative enzyme, but the main one you have to know is caspase. So what happens exactly now? The mitochondrial damage and dysfunction lead to the loss of electron transport chain. You're like, wait. What is this electron transport chain? It was back in biochem, if you remember. Well, I know that most of you did not do biochem yet, but still, overall, when we take oxygen inside of our body, why it's important? It's important for the process of making us ATP. To make ATP, you need oxygen. The need of oxygen comes from the fact that the oxygen works on the complex 4 of the electron transport chain. That complex 4 basically help make you some gradient that will explain it deeply in the future and how it works. So just simply here I will Google electron transport chain just to show you it. So if you get a question, where is the electron transport chain located, you have to say it's the intermembranous space of the mitochondria. So here it is. You saw the organelle, like the mitochondria. This is a mitochondria. The mitochondria has two membranes. So this is one membrane, outer and inner. And inside is the matrix. So you can see here, in the inner membrane, you can see the electron transport chain. If you get a question, where is the Krebs cycle located? The Krebs cycle is located inside of the mitochondria. Know this. And if you get a question, where is the glycolysis located? It's in the cytosol. Cytosol, it's outside of the mitochondria. Okay, so Krebs cycle happened. It made you a lot of NADPH that will go through the electron transport chain, and you can see here the oxygen at complex 4 working. That will lead to long process that we'll speak about, but eventually you will have ATP from the complex 5. If you don't know this, it's totally okay. Don't worry about it. It will be one of our last topics in the course. Anyway, I just told you this just to know that if the mitochondria burst, the electron transport chain will be lost. If the electron transport chain is lost, there will be no oxygenation of our cells. That will lead to decrease in the ATP. Decrease in the ATP, well, that's it, cell dead. The second thing you have to know is the cytoplasmatic vacuolation, which combines programmed cell death. So as we said before, yesterday, we said there is two types of death, apoptosis and necrosis. Sometimes the cell dies not because of like an external stress that forced it to die, but it just decided to die. Okay, like for example, if you remember yesterday, we spoke how in our fingers during embryology we have these webs. So there is webs here, and due to the process of apoptosis, these actually get removed. So this is programmed. You must have this. And apoptosis is super important. If we do not have the process of apoptosis, which is like programmed cell death, you can count how many cancers the patient will have. Because what is cancer? It's hyperproliferation of the cells. So apoptosis must be in our body to keep the cells from being overgrowing. Well, some person would be like, okay, let's inhibit apoptosis. Can we do that? Yes, we can. Should we? No, we should not. Why? Because there will be cancer. So the next one will be rupture. So as I told you, it's tearing. So there was tearing of the cell wall, tearing of the mitochondria, now tearing of the lysosome. Lysosomes has what inside of them? Hydrolytic enzymes. So that will go outside and just will be like kamikaze, kill everything around it. The next thing is a nuclear degradation. So we have something called pycnosis, karyolexis, and karyolysis. You have to know not these words, the pycnosis, karyolexis, and karyolysis. You have to know what they mean. That's what they ask. You don't have exactly to know how they look, but you absolutely need to know what they mean. So the first one is pycnosis, okay? It's like, I just like used to say myself, it's pycnosis, it's like pointosis. It's like pointing at something. So it's like a nuclear condensation. All of the nuclear material inside of the cell, as you can see, has been clumped up. Initially it was clumped, but now, so you can see here the clumping of the nuclear material was in this area, here clumped in 4 groups, but here, look what happened. It all inside of one singular solitary area. That's pycnosis. So the next thing is karyolexis. What is karyolexis? See this material? It will start to be cut into smaller fragments. Well, who can cut it? Well, you need something that can cut the nucleic material, nucleic acids. What can cut the nucleic acid? Endonuclease. So endonuclease are the enzymes that help to cut this. Well, what has activated them? How they become activated? Remember the only enzyme I told you have to memorize that is not written in first aid? Correct. Caspase. So caspase activate this one. The last thing that happens is karyolysis. So this cleave destroy particles. Basically what happens to them now that they just start to dissolve and they disappear. So the last thing here is there will be sometimes this enforced densities inclusion inside of the mitochondria. So it's a little bit before that, but when you look inside of the mitochondria, there will be some inner accumulations. We'll speak about this later because it will be important for another topic. So again, to make it simple, if you don't want to memorize all of this, just remember 2 words. Swelling, tearing. So here everything swells. So when the endoplasmatic reticulum swelled, ribosomal detachment. When the mitochondria swelled, what happened? Well, it was swelling, and a little blob started to happen inside of it. And the last one, when the cell itself started to swell, there was a blobbing. And they actually do mention for you the blobbing thing, so be careful. If they tell you about the blobbing and they ask you, well, if the stress goes away, what will happen? Total reversal. Nothing. Okay, so the next one here, it's the tearing. So what gets destroyed? Membrane. So membrane destruction of the cell wall itself, membrane destruction of the mitochondria, which lead to the loss of electron transport chain, and also the endoplasmatic reticulum get destroyed. So in this area, you can see only like a smush of cells, like this weird accumulation of everything together. When you see that, that's basically just necrosis, as simple as that. Okay, I hope this page makes sense. It's not that difficult of a page. Any question before we continue? Good. So now let's speak about the process of apoptosis. By the way, guys, now there is less of you, so it becomes more comfortable. Like if you wanna share something, say something, it's okay. Like we are not a lot here, we are only 11 people. You can say whatever you want, you can ask a question, all will be good. Okay, so I want you to know one word. Remember the caspases, I told you that they are super important. sometimes in the USMLE they started to know that, okay, students know what these caspases are and how they work. And since the student know that, they decided to, well, basically give them another name. Why they give the other name? To confuse you guys. So look here. The caspase is an abbreviation actually. It's an abbreviation for cysteine aspartic acid proteases. Please write this down. Apoptosis, in apoptosis, the caspases that used to be stimulated inside of the cells to activate another hydrolytic enzymes. The word caspase is the same as saying cysteine aspartic acid protease. Good. Okay, so let's move on. So what is apoptosis? It's suicide, the ATP dependent programmed cell death. Wait a second, there is an important thing here. ATP dependent. So you are telling me that you use energy to kill the cell of your body? Exactly. So to kill the cells in a programmed fashion, we require the presence of ATP. And and it's a programmed. Why this is important? Because necrosis is not a programmed. Necrosis, we are forced to do it due to the stress. But the apoptosis is physiological most of the time. So here we have the following. There is two pathways to kill a cell. There is an intrinsic one, also called the mitochondrial one, and there is an extrinsic one, which is also called the death receptor pathway. We'll explain each one a little bit deeply now. So, both pathways are activated by caspases. The caspases, remember about these guys, are the cytosolic proteases, which I told you have to know the full name. Please know it. So when these guys get activated, there will be cellular breakdown, including cell shrinkage. Remember about the shrinkage we spoke about? Chromatin condensation, that was pycnosis, if you remember. Membrane blobbing, due to the dysfunction of what? The sodium-potassium pump. And formation of a apoptotic body. This is the important area in apoptosis, the apoptotic body. What is apoptotic body? Well, it is something like this. If we have a cell, this cell. So this cell decided to die and it wants to commit suicide. Well, it does not want to make it rash all over the place, you know. So it does something like this. It releases the caspases inside of it. There is multiple pathway. Let's not get deep in this now. But what it will do is that it will just divide itself into smaller portions, okay? Why smaller portions? Well, the smaller portions are for the macrophage. The macrophage is a big cell. The macrophage. So he can come and eat these basically apoptotic body. So this we call apoptotic body. Okay? And the macrophage eats them. And to be able to eat them, they need to be smaller. So who does that? The process of apoptosis. So the process of apoptosis destroys the inner organelles, destroys the cytoskeleton inside, and divides it into small apoptotic body. So who can eat it? Correct, the macrophages. So that will be MF. Okay, by the way, in the future, I will always, when I want to say macrophage, I will just make this cell and write in the middle like M and phi, MF, macrophages. Okay, so there will be cellular breakdown, including cell shrinkage, chromatin condensation, membrane blobbing, and formation of a apoptotic body, which are then phagocytosed, and we said how that happened. Okay, they are characterized by a deeply eosinophilic cytoplasm and basophilic nucleus. Pycnosis and karyopyxis. This is super important concept to know. So during apoptosis, the cytoplasm will be eosinophilic. Eosinophilic means pink. Basophilic means blue. Okay. So let's take a look at it. If you take a look at the process of apoptosis, cells, let's take a histology of it. So you look here, there is so many cells, but you don't care about any of them. You just look for the pinkish one. See this pinkish one? This is the one undergoing apoptosis. So the moment you see the pinkish one, you know that that's the one undergoing apoptosis. The other ones are healthy. Well, some people will be like, oh, there is bichnosis of the nucleus. That's pretty difficult to see. But the pink cell are really easy to spot. That's why there is this concepts of red neurons. Have you ever heard about the red neurons? It will be present in case of histology of someone with a stroke. If they ask you what is the first histological signs you are going to see in a patient with a stroke, it will be red neurons. See these red neurons? Why they are red? Because they are undergoing the process of apoptosis and eventually it will be necrosis. We'll speak about that in a moment. So I hope you can see this eosinophilic material inside of the cytoplasm, and that's inside of the brain. These are pyramidal cells basically. If you are not good in histology, don't worry too much because there is ways to make all of these pictures easy and to understand them. You are not required to become a pathologist, you just need to know what are you looking at. So here we have the follow. They say cell membrane typically remains intact without significant inflammation, unlike in cases of necrosis. So this is super important concept. Whenever they tell you look what happens. In apoptosis, we did not have tearing of the cell wall. No, we have divided it into small parts, but we kept the cell wall. So nothing leaked outside. So nothing leaked outside, that means there was no inflammation. So there was no post-apoptotic inflammation. Is this physiological? 100%. If the process of apoptosis happens, there should be no inflammation. Okay, what about if the process of necrosis happens? Will there be inflammation afterward? Absolutely. In case of necrosis, there is an actual tear of the cell wall, and it's just like garbage going all over the place. So the immune system will be like, oh, garbage all over the place, I have to attack that. And it does. That's why we have post-MI myocarditis, fibrinous pericarditis that we'll speak about. And we'll speak how to differentiate it from Dressler syndrome. So there is a lot of concept to speak about that. Okay, so let's go back here. To make it simple, apoptosis is followed by acute inflammation, necrosis is not. So last thing I want you to do is to know about this DNA laddering. In first aid, they say DNA laddering fragments in multiple of 180 BP is a sensitive indicator of apoptosis. When a student read this, they just become like, what the hell is that? I never heard of such concept. And you are kind of true. So what is this? It's a method of electrophoresis. Okay, what is electrophoresis? They basically take the material they want to divide, put it on a gel, activate electricity, and it starts moving according to its density. So the BB is basically what? It's unit. So if they put it and they see the cells all at the 180 BB, which is like the difference between them is 180, that means that these cells are undergoing which process? Correct, apoptosis. So how they ask you this in the exam? Because it's just hell to try to calculate it. Well, they will not tell you, show you this and tell you to like minus and plus and do all of that stuff. But if you do, it will be 180. Like if you do 720 minus 540, it will be 180. If you do 540 minus 360, it will be again 180. So if these fragments are repetitively 180, that means that the cells have undergone which process? Correct, apoptosis. So let me actually put this picture here, and I will be adding the important pictures that we review in this group. Okay, so moving on, we have the following. To activate apoptosis, one of two processes should be done: the intrinsic pathway or the extrinsic pathway. The intrinsic pathway is totally normal. It involved in tissue remodeling in embryogenesis. Let me show you this. Have you ever heard about a child who has two fingers stuck together? Like they born and they have two fingers stuck together in a one area. Like I think they call it like finger synchia. And oh, sorry, not that one. but basically they are stuck together. And when they are stuck together, the reason of that is the absence of apoptosis. If they ask you about this, it's the absence of the it's the absence of apoptosis. Like there is also this web between, yeah. Yep. Well, this is normal. We have it. Why? Because the process of apoptosis did not occur here. Maybe you heard about the mermaid boy. Like there is this mermaid boy that have like the two legs connected together. Is the same idea. Why the two legs have not divided from one another? Due to the same idea of the absence of apoptosis. Okay, let's go back to the text. So yeah, the intrinsic pathway involved in tissue remodeling and embryogenesis. It occurs when a regulating factor is withdrawn from a proliferating cell population. So what is that again? So for cells to proliferate, let's say that this cell wants to proliferate. Let's imagine that, any type of cell, it doesn't matter. And the growth hormone of that cell, it doesn't, that growth hormone doesn't mean somatostatin always. It can be any type of growth hormone. It can be like this growth hormones, like fibroblast growth hormone, or something that lead to angiogenesis. So growth hormones are variable. So this growth hormone will come and tell the cell, proliferate for me. And it will start dividing and proliferating, making more cells. So the growth hormone will go and tell them, cells, divide for me. So it will do it again and again and again. Until when? Until the growth hormone goes away. When the growth hormone goes away, the cells will stop wanting to divide. Why? Because the growth hormone is not there. So I hope it makes sense. So it's involved in the tissue remodeling and embryogenesis, occurs when a regulating factor is withdrawn from a proliferating cell population. For example, when there is decrease in the interleukin 2, after a completed immunological reaction, there will be an apoptosis of the proliferating effector cells. Let's imagine this. I hope you don't know this, but in immunology we'll explain how there is this interleukins. They are cytokines, basically signal material that goes and tell each cell what to do. So interleukin 2, for example, it has the function of activating the T cell. I don't know this because I'm smart. No, I know this because there is a mnemonic for that. Hot tea bone stick. It's like a mnemonic that helps you memorize every interleukin and what it does. I will add it in the group after the class. So the interleukin 2 normally activates the T cells. And like, let's imagine this is the T cell. And like it can be cytotoxic T cells like the CD8 or the CD4. And so the interleukin 2 be like cell, proliferate, go and kill that infection for me. Okay, so we're like, okay, we are proliferating and we are going there. After some time, the interleukin 2 goes away. So the cell has no purpose to be proliferating. So it has to die. But if you want to kill a cell, you want to do it like in a programmed fashion, not to lead to acute inflammation afterwards. So how to do this? Apoptosis, correct. So it will just make it become smaller and smaller. And who will come and eat it? Correct, macrophages. Okay, good. So, yeah, after inflammation, what if they tell you blah, 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 long story short, there was lymphocyte in the tissue or neutrophils in the tissue, and after that they disappeared after the inflammation has finished. How come? Well, it's due to the process of apoptosis. It also occurs from the exposure to injurious stimuli. Yes, like what? What can lead to destruction of our cells? Well, hypoxia can do that. When you have hypoxia of the tissue, that leads to both necrosis and apoptosis. You get two in one in that case. Same with toxins and radiation. I hope you know about radiation injury. Really quick, radiation injury, there is a couple of stuff you have to know about. So the first thing, there is acute radiation injury and there is like post radiation injury. The first thing you have to know about acute radiation injury, that all of the cells that proliferate quickly will be destroyed. What cells proliferate quickly? Skin, GI tract. So the patient will have constant diarrhea that is really bad, and all of his skin will be burning. It will become red. And if God forbid near you happens a nuclear disaster, what is the first thing you have to do? What you have to give your patient? I hope you said iodine. We give the iodine to protect the patient, what? Thyroid gland. How come the thyroid glands get protected if you give the iodine? Because the thyroid gland will be consuming all of that iodine, and it will prevent the consuming of the radioactive material, and when that happens, the cell basically will not die of the thyroid. That's one thing. Also, if they do not consume the radioactive substances, they will not mutate, and if they will not mutate, you will have decreased risk of papillary thyroid cancer. Okay, so it is regulated by the BCL2 families of a protein. When I tell anybody about the BCL2, they always get confused. So to make it simple for you, we said the intrinsic pathway is related to what? Mitochondrial pathway, they say. If I want to name it mitochondrial pathway, it has to have some relationship to the mitochondria, obviously. So let's tell you what is that relationship. So just for sakeness of this lecture, just imagine that this is a mitochondria. I know that the walls are not straight, but this is a mitochondria. The mitochondria, around it, there is the following. There is like these guards. These guards protect the mitochondria. We call them the BCLs, okay? BCL2, and these are the guard of the cell. They are against destruction. So they must be good, yeah? Not always. So this BCL2 prevent apoptosis process from happening. How? By protecting the mitochondria of the cell. Okay, what is their enemy? Because any guard has an enemy. Well, the BCL family proteins, which protects the mitochondria, have two enemies, the backs and the back. They are the pro-apoptotic. So these are anti-apoptotic and these are pro-apoptotic. So the backs and the back are the enemies. So these are always fighting with each other. Backs want to kill, BCL want to protect. And we need to always have this homeostasis between these two. Not to have one more stronger than the other. You'll be like, no, let's have BCL more stronger than the other, we have less death. Yes, well, some cancers have over-secretion of the BCL2. When you have overstimulation of the BCL2, the cells will be hyperproliferating, which will lead to cancer. So that's dangerous. You don't want that. So apoptosis is a physiological process that you actually require. Okay, so the BCL2 family, yes. So there is many of them, but you only require to know that the BCL2, and for just completeness sake, there is the extra large one. I just imagine it like this. So there is the also the BCL2 and the BCL extra large, just XL. It's not extra large, but I just say it for completeness sake, just to understand it. Okay, so the backs and the back forms bore in the mitochondrial membranes. I told you that they are the bad guys. They want to destroy the membrane. And if the membrane actually does destroy, there is something inside. What they are protecting all of this BCLEs? They are protecting the thing that I'm drawing in green. It is something called the cytochrome C, okay? So that cytochrome C inside, if the backs and the back become successful and lead to bore inside of the mitochondria, the cytochrome C will escape. Well, let it escape. What is the big deal? Well, it is a big deal. Because if it escapes from the inner mitochondrial membrane and goes to where? It will go to the cytoplasm. Remember about these guys? Caspases will be activated. What are caspases? They are basically your typical antisocial. They will kill everybody around them and they will not feel guilty about it. They really don't care. They do good stuff for the community, but they don't know why. But yeah, caspases are basically kill anything inside of the cell. Okay. While BCL2 keeps the mitochondrial membrane impermeable. So we spoke about how the BCL2 protects the cell, protects the mitochondria. No need to re-explain that. thereby preventing the cytochrome release. Yes, so the BCL2 function is to prevent the cytochrome C from being released. Okay, so let's speak about really important cancer. It's called the follicular lymphoma, which is due to BCL2 overexpression. So let's imagine here, the BCL2, you have a lot of it. The back and the backs have no chance. The BCL2 will be able to protect the mitochondria in all cells. If that is true, the cells will keep dividing. If they keep dividing, the patient will have follicular lymphoma. So, I hope you remember that follicular lymphoma has this translocation that we'll speak about when we do hematology. It's 1418 translocation. Okay, so yeah, and I used to have a problem remembering like which number it is, so I told myself it's like 14 follicular. Okay, hope that helps. So in case of follicular lymphoma, there will be decrease in the caspase activity. Why? What led to activation of caspases before? Cytochrome C. Well, how is that related to this? Because cytochrome C normally gets released if you don't have enough BCL2. Well, now you have more than enough. No no cytochrome C release, thus decreased caspase activity, thus tumorigenesis. So all of that was the intrinsic pathway, also called the mitochondrial pathway, because it requires the mitochondria to release the cytochrome C. Okay, so if there is an intrinsic pathway, there must be an extrinsic pathway. So first of all, let's speak about this area of the graph down here, and then we'll explain about this area. So this is the intrinsic pathway, and this is the extrinsic pathway. But look who's in the middle, our amigo, the expandables. He kills everybody that he sees. Remember, our typical psychopath. So on the left, you can see the intrinsic pathway. We have DNA damage, and when the DNA damage, what can lead to DNA damage? We just spoke about it. Like the radiation injury, if you remember, like here, like due to Chernobyl, Hiroshima, Nagasaki, Fukushima, anything. And what is ROS? It's reactive oxygen species. If you cannot find the abbreviation, please write it down. It's reactive oxygen species. Well, what are these? Well, you know the thing that you do every single day? You inhale and exhale. When you put oxygen into your body, you are actually destroying it. Really? I kill myself by breathing? Yes. Well, oxygen can become a free radical. Yeah? So these free radicals can create a reactive oxygen species. Like, well, we have hydrogen peroxide, all of these guys. Well, hydrogen peroxide, do you mean the same one we use like for cleaning toilets and the cleaning wounds? Yeah, that one. It's also in your body. Also, we have a creation of a bleach in our body, the same thing that some people use for clothes. And also toxins can lead to DNA damage. So if there is a DNA damage, what happens? If there is DNA damage or hypoxia or a misfolded protein, there is variety of them. For example, a cell started creating a lot of misfolded proteins that are functionless. So the body be like, well, I don't need this cell if it's functionless. I need to destroy it. How to destroy it? So it's actually a protective mechanism of your body. When the cell is ruined, he decides to kill it at all. Like merciful euthanasia of the cell, I like to think about it. So the cell is really messed up and it's really useless. Why I need to give energy to it? Let me just destroy it. So in these cases, there will be activation of something called the B53 activation, and that's a really important gene, guys. The B53 system, we'll be speaking about it deeply in microbiology, in cancers, and reproductive. We'll keep speaking about it. So just know it from now. It's B53. So I will keep coming back to this page to annoy you and ask you what it encodes for, and you have to tell me the backs and the back. So what the backs and the back used to do? They used to want to create pores inside of the mitochondria to release what? The cytochrome C. What used to prevent that? The BCL2, the guards. Remember, we had two types, BCL2 and BCL extra large, XL. Okay, so if the cytochrome C goes out, we have something called the initiator caspases, and when this gets activated, done. it will start destroying everything inside of the cells. Yeah, just like you have activated a bomb that cannot be stopped. Okay, so that's the first pathway. Oh, by the way, see this cytoplasmatic blip? You can see it has like degraded organelles inside of it, but it has a cell wall, which is important. That's why you don't have inflammation, because nothing went outside inside of the serum. And the macrophage comes and it eats it. Okay, all of that was the intrinsic pathway. That was the difficult one. Now I'm going to explain the easy one, and after that we'll take a little break. So the extrinsic pathway, also called the death receptor pathway. So the death receptor pathway, it's not a simple pathway, but it's not as difficult as the intrinsic one. I just want you to calm down and understand that inside of the extrinsic pathway, there is two other pathways under it. Like there is two ways to kill the cells extrinsically without including the mitochondria. Because if we include the mitochondria, it becomes intrinsic. So no mitochondria, not intrinsic, so extrinsic. So extrinsic, death receptor, what does that mean? That means that there is a receptor that leads to the death. Oh, makes sense. Okay, good. So let's take a look. Two pathways. So ligand receptors interaction. Well, basically there is a ligand that binds to a receptor and it kills the cell. As simple as that. So what are these ligands and what is the receptor? Well, there is two of them. Take a look here. So we have the Fas ligand, it binds to the Fas receptor. And we have the tumor necrosis factor alpha that binds to the tumor necrosis factor receptor. We heard all about these guys. They were in something. Where it was, we'll speak about it in one moment exactly. So yeah, they're right here. The Fas binds to the Fas receptor and the TNF alpha binds to its receptor. If this is not high yield, but if you would like to know it, the Fas is CD95 positive. It's not high yield, but if you know it, it's just like an extra point if it comes. So the immune cells, like the cytotoxic T cells. Oh, remember about the cytotoxic T cells. I hope you remember which CD marker they have. They have CD8, cytotoxic CD8, okay? While the helper ones have CD4, so cytotoxic CD8. Okay, so these are the cytotoxic T cells. They want to kill these cells. How to kill these cells? So first of all, to kill the cells by the extrinsic pathway, we spoke about the death receptor. The other way was to use the immune system. Extrinsic receptor binded to a receptor, and that activated the caspases. It led to the same deal like the intrinsic receptor. The other way the extrinsic pathway could kill a cell was by making enzymes. So what enzymes does the cytotoxic T cells make? It makes perforins and granenzyme B. You have to know the function of these enzymes. Perforin perforate, granenzyme B activate the caspase. So perforin perforates, so it makes the bore, okay? You have to know that perforin makes the bore here. And the granenzyme are these green balls that come here and activate the caspases. And after you have activation of the caspases, we have the apoptotic body that will be consumed by whom? The macrophages. Okay, so the Fas ligand interaction is necessary in thymic medullary negative selection. You're like, wait, what is this medullary thymic? What is negative selection? Well, in immunology, inside of our thymus, there is the boot camp for making us new soldiers. So to make new soldiers, which are basically your what? Your immune cells, they have to go through a process. To make a good soldier, you have to go through a few layers, basically. So let's imagine that this is the thymus. Why we say T cells? T for thymus, B cells, B for bone. Okay? So what does that mean? Where is the T cells made? If you said thymus, that's wrong. The T cells and the B cells are made in the bone marrow. That's a tricky question. Be careful of it. But where they mature, the B cells matures in the bone and the T cells matures in the thymus. Again, both of them are made in the bone marrow, but the T cells are matured in the thymus, while the B cells is matured in the bone. Okay, longer process. I will not go through it now. We'll go through it during the immunology chapter. But what I want you to know that when the cells come from the bone marrow, they go to the thymus, they have this positive and negative selection. Remember, in the beginning, we all have this positive idea about someone, and then it becomes negative. So it's positive, then negative. So where does the positive happens? From the outer layer to the inner layer. So positive outside and the negative inside. So in the thymic cortex, which is the outside, you will have what? There will be checking of if your cells inside of if your like T cells that came here, they check them. Are you able to bind our self MHC, like the MHC receptor that is located on all of the cells of the body, the MHC1? If he's capable of doing that, they will keep him. I like to think about it like dating. The first expression. Well, did you like the guy? Well, yes, I did. So keep him. Think about it. I did not like him. Initially, like there is no chemistry, no contact between you. Okay, just kill him. Oh, well, I'm kidding, but in this case, you just destroy him. How do you destroy him? Apoptosis, correct. Okay, if he passes and you like him, he goes to the next step, which is what? In the medulla, negative selection. What does it mean? Well, yeah, there is chemistry between you, but if he binds too much, he's too needy type of thing. He binds too much. He's really annoying by binding too much. What do? You also kill him. So you want him to bind, but not too much. So positive selection. If you have cells that are capable of binding, your self MHC receptor, which is located in all of your body cells, you keep it. But if it binds too much, you kill it. Why we kill it if it binds too much? Because if it binds too much, it can lead to autoimmune disease. If it does not bind at all, it cannot kill our cells if they are infected. So it's useless basically. So I hope you know how when I keep saying we kill our cells, that's the process of apoptosis basically. Okay, so now we can read, and hopefully it will make sense. Fast to fast L interaction is necessary in the thymic medullary negative selection. And now it makes sense. You can read it and you can understand how it happens. So the fast L interaction happens where? In the medulla of the thymus, and if they see that it binds so much, they will just kill it. So the FAS mutation increased number of the circulating self-reacting lymphocyte due to failure of clonal deletion. So imagine if the FAS is not working, this guy, and it cannot lead to medullary negative selection. It cannot lead to negative selection. So you remember about that needy guy who wants to bind so much? Yeah, exactly. So he will be attaching to a lot of cells when you don't want it to attach to. And that will lead to what? Excellent. Autoimmune diseases. So yeah, if you have dysfunction of the medullary negative selection, which occurs inside of the thymus of the T cells, you will get autoimmune diseases. You don't want that. Okay, the last thing, if you get a defect in the interaction itself between these two all over the body, you can get multiple autoimmune disease, because we said about the relationship of how it destroys like the T cells who attach so much. So you can get autoimmune diseases all over the body. So we call them autoimmune lymphoproliferative syndrome, which means you can have multiple autoimmune disease at the same time. If you don't know what that is, don't worry too much. We will see it in the future. But autoimmune lymphoproliferative syndrome is basically if one person have like a 3 or 4 autoimmune diseases at the same time. Okay, so now we will have like a little break, and we'll continue after the break. I hope these two made sense to these two pages. We are moving a little bit faster than yesterday, which is good. And every day will be faster than the day before it until we'll be able to finish 5-6 pages per hour. Anyone has any questions? Excellent. So I will see you guys in exactly 10 minutes. Welcome back, guys. So now we are going to speak a little bit about different type of necrosis. So we spoke about apoptosis, now we'll speak about necrosis, and we will speak a little bit more deeply about it. So let's take a look. Necrosis. So this is totally pathological. Necrosis cannot be physiological, and if they mention any physiological process and you hear the word necrosis, it cannot be. They don't fit these two answers together. So necrosis is an exo from the outside genus injury that lead to plasma membrane damage, and cell will undergo enzymatic degradation and proteins denaturation. What does that mean? So when the plasma membrane is destroyed, what will happen? Well, there will be a lot of calcium inside of the cells. When that occurs, if you remember what that lead to activation of what? Correct, caspases. So cell undergoes enzymatic degradation and protein denaturation. By whom? The caspases that activated another hydrolytic enzymes. And there will be intracellular component leak, like troponin if you remember. And there will be local inflammatory reaction, unlike apoptosis. So in apoptosis, the cell membrane in the little particles that stayed after the apoptosis has occurred, the apoptotic body, prevented the release of the internal content to the circulation, which prevented the post-apoptosis, from creating inflammatory reaction afterward. But in necrosis, it's just like a cell destroyed, everything released all over the place, so there will be local inflammation following it. So there is various types of necrosis. We have the coagulative, liquefactive, caseous, and fat, fibrinoid, and lastly gangrenous. Each one of these looks disgusting, but you have to know how they look like, what they are due to, and which organ they affect. And lastly, you need to know the histology of them. So let's start with them one by one. I might be jumping back and forth a little bit here, but overall the idea is one. The coagulative necrosis, I want you to know that this one is the most common between all of them. And it's seen in cases of ischemia and also in cases of infarction in most tissues, except the brain. Well, if I write except the brain, what does the brain have? It has liquefactive. Well, what is the difference between coagulative and liquefactive? The structure, guys. Coagulative necrosis, when it occurs, the structure of the cells stays the same, while in liquefactive, it changes, like it gets altered. I will show you an example of this. So if I show you here kidney histology, like I will show you just like normal kidney histology. Take a look at this. This is a glomerulus, these are tubules, so all good, like it's totally normal. If I take kidney and I just write next to it necrosis, and we take a look at histology of it. Well, take a look at this one. Yeah, so that's acute tubular necrosis, for example. What is the difference between this one and this one? This one, this one. Look at the nuclei here. They are absent inside of the tubules. Here, they are present, absent, present, absent. So if you remember one sign of, oh yeah, this is even a better one. There is no nuclei, which means it's necrosis, but the structure overall is the same. So this is an example of coagulative necrosis. I like to imagine it coagulates everything in its place. Okay? So here we have ischemia infarcts in most tissues except the brain. It will be due to ischemia or infarction, and it will lead to and the injury will denaturate the enzymes, which lead to proteolysis blocked. So why, if the proteolysis will be blocked, will you have destruction of the structure of the cells? Not really, you will not. If you don't have the destruction of the structure of the cells, the structure will be preserved. So they write preserved cellular architecture. Cell outline will be seen as we saw in the picture of the kidney here, as you can appreciate in this picture. Okay, and yeah, after the class I would like someone to reply for each picture and write what it is. Everybody of you have to do one of them. Okay, so yeah, preserved cellular architecture, cell outline will be seen, but nuclei disappear as we saw in the picture. There will be more cytoplasmatic binding of auxine stain. Do you remember when I showed you the red nuclei? Yes, the same idea. So there will become eosinophilia red-pink color. So let's take a look at them. Okay, so this is an example of it. Really bad example because the architecture is not seen good here. You cannot even determine which tissue it is. But if I was in your place, I will just focus on this example of the kidney. So you can see that it's tubules and it's kidney, glomerulus here. And yeah, simply no nuclei, but the outline is preserved. That's an example of coagulative necrosis. Okay, good. Okay, let's keep going. We have liquefactive necrosis. Since we here said every tissue in our body except, correct, the brain. So it will be the brain and what else? Bacterial abscesses. Well, brain, I get it, but why bacterial abscesses? Because they have neutrophils. And the neutrophils releases lysosomal enzymes that digest the tissue. You are like, okay, now I get bacterial, but I don't get the brain one. Why the brain can lead to this? Have you ever heard about a cell called microglial cell? The microglial cell is basically the main one that can lead to liquefactive necrosis. Microglial cells are basically the macrophages of the brain. So the microglial cells, in case of liquefactive necrosis, are the one creating the liquefactive necrosis. And since the brain cannot have any other cells to come and clear out the infection from the inside as good as the other systems, it will become a little bit fluidy. So let's take a look. Bacterial abscesses and brain infection. Brain infarctions. So neutrophil release lysosomal enzymes that digest the tissue. So let's take a look at it. Look at the brain. Here we have like a stroke, a previous stroke. So let's take a look at the stroke gross picture. Okay, you can see it's like there is some form of jelly in it. So it's liquefactive. Yeah, that's an infarction. Here it is on the brain, all over the place. Here it's affecting the hippocampus even. It's an infarction in the MCA. In the near future, you will be able to look at the CT and to differentiate which exact artery is occluded. Okay, so that's liquefactive necrosis, and there is early signs and late signs. Early on in histology, you will see cellular debris and a lot of macrophages there. That's not high yield. But what is high yield is this one. Cystic spaces, as the one we saw in the brain, and cavitation in the brain will be seen. Neutrophils and cell debris will be seen in case of bacterial infection leading to an abscess. So again, liquefactive necrosis can be in case of an abscess and in case of the brain infarction. If they ask you what is the method of its creation, you will say it's neutrophil mediated. Okay? If you say how it is mediated in the brain, you will say it's microglial cells mediated. Okay, so the next concept. I hope you like cheese, because you will not like it anymore. Cassius infarction. Cassius infarction is the cheese-like infarction. When you hear the word Cassius infarction, think infectious disease. So, yeah, infarction. Okay, you can see this yellowish area. That's an example of Cassius infarction. So what is the causes of it? Not anything, but mostly stuff that will be infectious. For example, anything with myco in the word. What do I mean by that? Mycology and mycobacteriums. So Mycobacteriums is like Mycobacterium TB, which is an acid fast, and Nocardia as well, which is also an acid fast. And when I say mycology, it's like the fungi, the science related to fungi, we call it mycology. So for example, the Histoplasma capsulatum in this case. Keep in mind the Histoplasma capsulatum, for the USMLE, you have to know that it's located in the northeastern area of the US, especially an area called New England, which is the northeastern area of the US. That area also has other diseases like Lyme disease. Okay, you need to keep that in mind. Okay, so TB and the other fungi and nocardia, systemic fungi. Systemic fungi are not only histoplasma, there is also coccidiomycosis and blasto, so there are and barococcidiomycosis as well, so there is quite a few of them. We'll study them deeply, don't worry about them now. Anyway, what happens is that in Cassius necrosis, it's macrophage mediated. So the macrophages wall off the infecting microorganism. Why? Well, in case of TB, the macrophage comes to eat the TB, right? So here is the macrophage, the strong guy. He comes, he's like, oh, hi TB, I want to eat you. But he cannot. Why? Because the macrophage come to eat it, and he does. It's inside of him. Like the TB be like, okay, I'm even attracting you. If you want to come to eat me, come to eat me. So the TB will go inside of it. And then it will use something, and you have to know the name of this something. It's called the chord factor. Okay? And the chord factor tells the TB, well, I'm inside of you right now, and you cannot digest me. And the TB cannot digest it anymore. What makes it worse is that the TB will be like, see my chord factor? Go bring me your friends. I'm not only satisfied by taking you as a prisoner, I want your friends to come as well. So the macrophages will all come from all over the body to kill the TB. So they will surround it, but they cannot kill it because of the chord factor, because of the chord factor. So what they do? They start building a wall, okay? So they build a wall around the cell, and that wall that is built, basically it will lead to what? To the TB not leaving, but it stays. It's just a solitary lesion that stays here. Nothing goes in, nothing goes out. It's just a wall, and Mexico has to pay for it. So, the next one. So, Cassius necrosis, it can be due to macrophages wall off the infecting microorganism leading to a granular debris. Let's take a look at that. So, you can see in the pictures C, it's like this cottage shape, cottage cheese-like appearance, yeah? So cottage cheese, just for those who don't know what that is this guy. Yeah, so it looks exactly like this guy. Bon appetit. Next. So the Cassius necrosis, what we are going to see in histology. Fragmented cells and debris surrounded by lymphocytes and macrophages. So what is that? The cells in histology will be destroyed. It's just a mush of cells, a lot of macrophages inside and lymphocyte. And also we have a creation of a granuloma. You are like, wait, what is a granuloma? Well, guys, do you remember this one where I told you there is a lot of macrophages surrounding the area? What will eventually happen, all of these macrophages are here, and they decide, okay, let's block the supply to that area. So what happens, the center of that area dies. So there is necrosis in this area. And here we have a lot of lymphocytes, and around them there is a lot of macrophages. We call that Cassius necrosis. Okay, so let me show you a picture of Cassius necrosis. Okay, Cassius necrosis, here, this is the pathology, gross pathology. But if you want to take a look at the histology, you can see the formation of a granuloma. So, let's take a look at the granuloma. Please keep in mind that there is two types of granuloma, Cassius and non-Cassius granuloma. So the Cassius granuloma has central necrosis in the middle, as you can see here. But the non-Cassius granuloma does not have central necrosis. Like there is here, what does necrosis mean? Remember, no nuclei. So no nuclei here, that's necrosis. But in case of non-Cassius Cassius Granuloma, there will be what? Look at this. No central necrosis. It's all like cells in the middle. So you are like, how can I differentiate? Why is like Cassius, non-Cassius? I can differentiate between them according to the look, but I don't understand what they are caused by. Well, Cassius granulomas are always caused by infectious disease. So we said mycology, histoplasmosis, blastomycosis, coccidiomycosis, paracoccidiomycosis, all of the mycology stuff. You will know it later. Also, Mycobacterium TB, tuberculosis, and nocardia. All of these lead to caseating granuloma. What about the non-caseating granuloma? Anything that is not an infectious disease. For example, Crohn's disease. I used to tell myself Crohn's disease, I imagine it as a Crohn's disease, so it has a granulomas. So yeah, Crohn's disease has it. Other autoimmune diseases has it, like sarcoidosis has it as well. And they do have it, but is it caseating or non-caseating? In autoimmune disease, it's non-caseating. In infection disease, it's caseating. So anything that is caused by microorganism will be caseating, correct? Okay, so far, coagulative, liquefactive, caseous, all good. Now let's speak about fat necrosis. It's that lady that get hit in the breast and after that she feels a bump in there. So let's explain what has occurred. Before reading deeply in it, I just want you to imagine a scenario. A lady who plays, that's how they bring it in the USMLE. Lady comes play volleyball, okay? And she does not remember that she was hit in her breast. Now she palpates her breast and she finds a mass. She's really scared because she thinks it's cancer, okay? So you do a mammography on her, you see microcalcification. And you know that in actual mammography, if you see microcalcification, you must take a biopsy. Why? Because also invasive cancer of the breast also has microcalcification. So you take a biopsy of her breast and turns out to be just normal fat cells. What brings fat to the breast? Basically, she was traumatized in her breast, but she did not recall that. She does not remember that she was hit. And after that, she has this mass in her breast. And that's a form of what? Fat necrosis. So there is two types of it. There is the enzymatic and the non-enzymatic. The non-enzymatic, I just told you an example of it. It's like trauma leading to injury of the breast tissue, leading to a mass. It just becomes calcified around it and the fat start coming in there and you have like a fatful biopsy with surrounding what? Calcification, correct, full with calcium. While the enzymatic one, it's due to acute pancreatitis, for example, and this is really cool. You know what is process of saponification? In Arabic, the word sabun comes from it gives this English word, saponification, which means making of soap. Soap for a cleaning hand, for example. So actually this exact same process is the process that we convert olive oil to make a soap from it. It's exactly the same. We use enzymes on the olive oil to make what? Soap. So you have soap in case of acute pancreatitis. Sound good. So you will be cleaner from the inside. Well, not really. You will destroy your pancreas. So saponification of peripancreatic fat. Please keep in mind that the pancreas is a tricky organ. It has two types of necrosis happening in it. So from the outside, it has like the peri, it means outside. It has which type of necrosis? The fat necrosis. But from the inside, it has totally a different type of necrosis, which we'll be speaking about in a moment. Okay, oh, sorry, we spoke about it already, but it's not mentioned here. It's liquefactive necrosis. So peripancreatic fat will get fat necrosis, internal portion of the pancreas in case of acute pancreatitis will be liquefactive necrosis. So you'll be like, wait a second, why liquefactive? You told me like in the brain it was the microglial cells, in the bacterial abscess it was the neutrophils. What about the pancreas? It's the amylase, guys. Write it down. So the next one here, the fat, what you are going to see in a gross picture, a damaged pancreatic cell, the pathogenesis. So the damaged pancreatic cells release enzymes like lipase. Which enzyme is more specific for the pancreas, lipase or amylase? I hope you said lipase. The reason lipase is more specific than amylase because of the fact that amylase is also secreted from our salivary gland. So it can be high in cases of parotitis, for example, inflammation of the parotid gland, which is a salivary gland. But lipase, on the other hand, is also only from the pancreas. So there will be release of lipase. And what is the function of lipase? It breaks down triglyceride, which liberate fatty acid, and that binds to calcium. So let me just explain this long process that might seem complicated for you guys. Just a little bit of biochem now. I want you to be comfortable with the following idea. When I say triglyceride, it's the following thing. So I'm drawing a triglyceride. I just want you to know the schematic. For the USMLE, mostly you are not required to know any chemical structure, but you have to know the schematic so you'll be comfortable with it. So the question comes something like this. What is the function of bile on fat? What is the function of the lipase on fat? It's a fair question to ask. So what is the function of bile on fat? It leads to the emulsification of the fat. What does that mean? Well, if we imagine you ate a piece of fat, this is a piece of fat. It has so many triglyceride inside of it. And this big picture here, this is a one big triglyceride. So this is a triglyceride. Triglyceride has a glycerol here and fatty acid, the three fatty acid, one here, one here, one here. And this is a big piece of fat, so the bile comes and divided to a smaller portions, okay? We call that process emulsification, okay? So the process of cutting one piece of fat into smaller piece of fat, it's called emulsification. If you want to see it in real life, guys, bring a little bit of oil, put some soap on it, from like this one for dishes, to clean dishes, and you will see a creation of little little balloons, yeah? And these little balloons are basically the process of emulsification of the fat happening inside of the dish. The same thing happened in your intestine from the bile. Okay, bile did its job. What about lipase? What it does? See the glycerol connected to the fatty acids? So these are fatty acids, all three of them. So this is a triglyceride. So the lipase comes, this is the lipase in yellow. He comes and cut one. So you release one fatty acid and it becomes diglyceride. It comes, cut another fatty acid. It becomes monoglyceride. Okay, it comes, it cuts the last one. So it basically digests your triglyceride. That's the function of lipase. I hope it made sense. So damaged pancreatic cells release lipase, which breaks down the triglyceride and liberates fatty acids, which we just spoke about how they look like. And the fatty acids that are liberated binds to whom? Calcium. And I'm drawing calcium in blue. You will know after 1 second why I made it blue. So, okay, so they start binding to calcium and they lead to the saponification process, basically making soap. Chalky white appearance. So let's take a look at a gross picture of acute pancreatitis gross. Okay, so take a look at that. So yellow, and you can see this little structure here and there, this whitish stuff here. This is what? This is basically the fat necrosis, yeah? It's which type? The enzymatic subtype. And here it is as well, okay? It's the yellowish stuff. What is this yellowish and whitish stuff here and there? These are basically the fatty acids combined with what? With calcium. Correct. So it's basically so. Okay, back to first aid. So the other thing here, they write the outline of the dead fat cells without peripheral nuclei and the saponification. So yeah, there will be an outline of the dead cells, obviously, so they will stay in their places, but there will be saponification process of the fat combined with calcium. Guys, you must know this. Calcium in histology always is a blue, okay? That's why I made this picture blue here. like the calcium, I made it blue. Try in your brain to always associate the calcium with the color blue, because in histology it always looks blue regardless of the fact what we are speaking about, and we are going to see it again in different pathologies. So know it now, so when we discuss musculoskeletal it will be much easier to comprehend. So acute calcification, we want to see the fat necrosis histology. Okay, can you see how the here it is. Can you see the bluish thing of this area? That's fat necrosis, and it has calcification on it. The same here. There is the preservation of the structure, but you can see it becomes bluish. That bluish is like calcium accumulating inside of it, and that's even better one. So this is the best one I saw so far. Let me send it to the group. Okay, so you can take a look at the picture here. You can see what? There is fat here, fat cells, and here you can see what? Basophilic material, that's what? Calcium. By the way, guys, this fat cells is not actually fat. You know what these are? Yes, it's fat, but in reality it's empty. Why? Because when you do the histological section, you put alcohol. And when you put alcohol in fat, the fat just dissolves. So it just empty spaces, which represents the area where the fat used to be. Okay, good. So let's go back here. So they say it appears dark blue on H&E stain. So let's take a look at it. Okay, you can see the bluish thing of it. But remember, the structure is preserved. Okay, so the next one, fibrinoid. So the fibrinoid necrosis, it could be immune mediated or non-immune. So the fibrinoid necrosis, the only immune situation you have to know is polyarteritis nodosa. And this polyarteritis nodosa is a type of vasculitis, which is an inflammation of the what? Of the vessels. So inflammation of the vessels in case of polyarteritis nodosa can lead to what? Fibrinoid necrosis. Please know the association of PAN, which is polyarteritis nodosa, with the hepatitis B. They always ask it. And in the same time, know that it's a systemic disease that does not affect the lung. And I repeat it, it does not affect the lung. Because if they give any patient with affection of the lung with vasculitis, it's not polyarteritis nodosa, it's something else. That helps you to rule out the answer. Please also know, all types, without exceptions, all types of vasculitides, which is like the plural of vasculitis, are type 3 hypersensitivity reaction. When we say type 3 hypersensitivity reaction, it means immune complex mediated. What is an immune complex? It is when you have an antibody, an antigen attached to it, and a complement. Okay? So when you have antibody, antigen, and a complement, we call that immune complex. And they just go swim inside of your circulation and attach to the vessel wall, accumulate inside of it. And when they accumulate inside of it, they look pinkish and beautiful, leading to fibrinoid necrosis. So let's take a look at how they look like. See this pinkish layer, outer layer? This is immune complex accumulation. Okay, guys? So, good. So it has two pathogenesis. In case of polyarteritis nodosa, it's the immune complex thing that I just told you. So it is immune complex deposition, type 3 hypersensitivity reaction. That's in case of vasculitis. Be careful. I think it's a typo in first aid or something, but there is something here like a little bit tricky. They write and or. So if you say a plasma protein, like the fibrin leakage from the damaged tissue, from the damaged vessel, yes, it can be secondary to the immune complex deposition, and that leads to the damage, and after that you have the fibrin leakage. Yeah, that's correct. But in case of hypertensive emergency and preeclampsia, it is only the plasma protein leakage from the damaged vessels due to the hypertensive emergency or preeclampsia. Okay, guys, so let's try to understand what is the difference between emergency and urgency, hypertensive emergency and urgency. In both of them, the blood pressure will be 180 over 120. But in case of emergency, there is end organ damage. What does that mean? The patient started to become confused, neuropathy. He started to have increased creatinine, nephropathy. he got a heart attack, cardiopathy. So you get the idea. But if it's urgency, it means the exact same, but there is no end organ damage. Why this is important? Someone with emergency, you put him in the hospital. Someone with urgency, you send him home with some tablets. Okay, so the fibrinoid vessel wall are thick and pink. Let's take a look at that. Can you see the pinkish material accumulating inside of the wall? Excellent, good. Okay, the last one of these necrosis types. So we spoke about coagulative, liquefactive, caseous, fat, fibrinoid, and now gangrenous. Gangrenous, we all heard about it at one point in our life. It like to affect the distalmost portion of our extremities, and also it can affect the GI tract. It was kind of difficult to find the one in the GI tract, but here it is. You see it, guys? So that's how it affects the GI tract. That's how it looks like. Okay, so it affects the distal extremity and the GI tract after chronic ischemia. So it can be after hernia that becomes strangulated. What is hernia? It's when one portion of your intestine goes out and then it twists over each other. By the way, guys, is this patient alive or dead? I hope you say dead because you can see his rib cage. You will never open that type of opening for a surgery. So yeah, he's dead. And yeah, the next thing here, like the gangrenous type has two subtypes. Okay, the first subtype is dry and the second subtype is wet. They are kind of really important. Look at this guy. He has gangrene in his distalmost portion of his fingers. So you highly suspect why he got this. Like if it was in one finger, I could imagine that he had an injury that now is moving. If it was in his foot, I can imagine that he is diabetic, but it's in his finger. So this patient actually has like thromboangiitis obliterans, which is due to smoking. So these people who smoke, keep smoking, get this. Especially if they are between the 30 years old until 50 years old. Funny enough, if they are more than 50, it doesn't happen. So the range is between 30 and 50. Okay, it's a type of coagulative necrosis. So if you do the histology, the architecture will be normal. While the wet type, it's the suprainfarction. And yeah, it's a liquefact. It will be suprainfarction. What does superinfection mean? Well, superinfection means that some microorganism has led to this due to a process of basically forcing the immune system to degrade it and the hydrolytic enzyme to degrade it. And when we say hydrolytic enzyme, we think about which type of necrosis? Good, liquefactive necrosis. So liquefactive superimposed and coagulative. So the patient initially have coagulative, but since the area become really inflamed, you can get liquefactive due to the presence of whom? Excellent, the neutrophils. Good. So okay, that was so far we explained cell injury, we explained apoptosis, necrosis, and we also explained cellular adaptation. Now I'm going to not to speak about this because we need to keep some time for the CVS. Tomorrow we'll continue that with the pathology chapter. Okay, so CVS. So for CVS we have the following. If you remember yesterday we spoke about most of the embryological structure, and guys, I need you to be really focused at this point. You know why? Because all of the questions I bring you today are about this topic. So please, know every single word from what I'm going to explain now, because basically they will give you the answers. And I will be asking you this question and you are going to write the answer in the chat. Don't worry, I made all of you the admin so nobody can know your identity. So, heart embryology. So, the truncus arteriosus, do you remember guys this one? It was the big trunk that comes from both your left and right ventricle, and it gave origin to both the pulmonary trunk and the aorta. Yes? after creation of a septum. So if this septum does not create in the middle, what will you have? Persistent troncus arteriosus. What is a persistent troncus arteriosus? So troncus arteriosus. If you take a look at it, yeah. So persistent troncus arteriosus, it will just be one big vessel that passes what and what? It will pass blood to both the pulmonary trunk and the aorta. So it will be a mixed type of blood. So that occurs in case of persistent troncus arteriosus. And normally this structure gives origin of the aorta and the pulmonary trunk. Good. Bulbus cordis, it's the smooth part, and you can see it here. So bulbus cordis, it's this guy, and it gives origin into what? The smooth portion of your ventricle. Yeah, this one, the uppermost portion. Please keep in mind that your ventricles have two portions. It has the trabeculated type, a trabeculated section, and it also has the smooth section. So two areas, and these two areas are given origin from different parts. So the bulbus cordis comes from the gives origin to the smooth area, while the trabeculated portion comes from the primitive ventricle, which is like the one under it directly here in pink. Okay, so the primitive ventricle, it's the trabeculated part of the left and the right ventricle. So I will get the question now, what does a trabeculation mean? So trabeculation mean it's when you look at the gross heart. Yes, if you take a look at the gross heart, look at this section. It's trabeculated here, which means it's irregular. But the uppermost portion of the heart will be regular, okay? So the chamber itself, the lower portions, irregular, upper portions, regular. You can see the trabeculation in here. And you can see the smooth area here. Okay, good. So moving on. So actually, sadly, you have to memorize this whole schedule because they do ask about it. What I used to do is just to watch a couple of videos about how the embryology goes, and I will send it to you, and just to try to rewind that video a couple of times and you will memorize it. I hope you guys know about Anki. If someone does not know about Anki, please contact me after the lesson. I will teach you how to download it, how to add a deck into it, and how to do that Anki deck so you can memorize the stuff from first aid. Okay, so the next one will be primitive atrium. So anything that has the word primitive, think about trabeculated. So it was a primitive ventricle, gave the trabeculated portion of the left and the right ventricle. Trabeculated atrium gave the trabeculated portion of the left and the right atrium. Okay, so far so good. So this is primitive ventricle. So here is the ventricle, primitive atrium. So this gives portion of the trabeculated portion of the ventricle. Atrium, bulbus cordis give what? The smooth portion of the ventricle. Good. And now we have the venous sinus. So the sinus horns are the ones down here. Please, I know that they are tricky. You have the left one and the right one. So you have the right one here, the left one here. Right one, left one. For the left one, just imagine, it's your coronary artery is the heart of your heart. Without him, you will not have any perfusion to your heart. And our heart is located on the left. So the heart of our heart is supposed to be located on the left, yeah? So I imagine it like this. Coronary sinus, since it's the heart of our heart, it will be going out from the left horn, okay? The right horn, on the other hand, give the smooth portion of the right atrium. Okay, endocardial cushion. Oh, guys, you know this. We spoke. They made a lot of structure about endocardial cushion. And now there is a question about it. I just told you, but I will not tell you which one. You will have to know it yourself. Endocardial cushion give the atrial septum. Remember, they connected with the septum primum. They also gave a portion, the membranous portion, membranous, not the muscular, membranous portion of the intraventricular septums. They also gave you all of your heart valves, both the AV valves and the semilunar valves. Keep in mind that the AV valves are the mitrals and the tricuspid, semilunar are the aortic and the pulmonic. So next we have right common cardinal vein and the right anterior cardinal vein. And we have the posterior subcardinal and supracardinal veins. These are tricky to memorize. So what I did personally with them, I just imagine anterior, superior, posterior, inferior. What does that mean? So when you say about anterior cardinal vein, it will be always associated with the superior, okay? So it's like up bend forward. Keep your head up bend forward. So up is superior, forward is anterior. So superior vena cava comes from which one? The anterior cardinal vein. That's what they ask. What about the inferior vena cava? Posterior cardinal vein. That's what they ask. The other minor ones here, they do not ask about these. Okay. The last thing, the primitive pulmonary vein. So the primitive pulmonary vein gives origin to the smooth part of the left atrium. Well, what about the smooth part of the right atrium? We just spoke about it, guys. The smooth part of the right atrium came from the right horn of the sinus venosus. What about the left horn? The left horn gave origin to the coronary sinus. Remember, the heart of your heart. Okay? Okay, good. Now we take a little bit of a break. We come back. We finish the rest of embryology, fetal circulation. Really important, a lot of question on it. We'll finish heart anatomy and we'll give you some question and we call it off for the day. Okay, guys, so we'll have a break now. So let me tell you how much is the break. Okay, guys, so now our last section for today. So today we are going to speak about two things. The first one is the fetal circulation and the second one is the cardiac anatomy. It can be a little bit difficult for most of the students to understand the CT scans and the X-rays, and that's mostly what we'll be speaking regarding the anatomy. For the fetal embryology, I just want one thing from you now. Everything you learned about the heart, about the cardiovascular system, how the vessels move, all of that, for just the next 10 minutes, I want you to forget, because in the fetus body, it's totally different. Totally different system. So, the first idea, I want you to know that the placenta, it's not for the baby, it's for the mother. So the placenta is an organ, but it's not the organ for the baby. It's the organ of the mother, okay? So, the placenta exists inside of the mother, gives the blood to the baby. But how does this happen? If you take this, what is this? This is the umbilical cord. If I cut it, what I will see inside of it? Inside of the umbilical cord, histology, you will see the following structure. So you can see two arteries, one vein, and you can see what? The allantoic duct, which will be really important when we speak about reproductive system. And what is this, the matrix? What is it made out of? Wharton jelly. So, the first question, why to umbilical artery? The second question, how can I differentiate between an artery and vein? The third question is which one has oxygenated blood, which one has the non-oxygenated blood. So again, let's see. Why they are two, why this is one, we'll speak about in a moment. But the next question, which was which one is oxygenated, which one is not, it's the opposite way around. So the arteries has the non-oxygenated blood, the veins has the oxygenated blood. And lastly, how can I take a look at this slide and know which one is an artery and which one is a vein? Guys, remember the histology of an artery? It has more layers than a vein. Arteries has this internal and external elastic lamina. Veins do not have that. So artery do not collapse. Veins collapse. Yeah? See how it collapses on each other? So it's a vein. It does not collapse. It's an artery. Okay. Now let's speak about the actual fetal circulation and why we have two arteries and one vein. So from the placenta, we have a blood moving from the placenta to the umbilical cord, and from the umbilical cord we have umbilical vein, and the umbilical vein keeps going And why do we call it vein? Wait a second, it has oxygenated blood because it came from mama. Look, it has high O2. So why we call it a vein? Because guys, remember what I told you yesterday. A vein is not, it doesn't relate, is it having oxygen or not having oxygen. Veins mean every single vessel in your body that goes back to your heart. Artery is every vessel of your body that is exiting or going away from your heart. So vein is going towards the heart. So umbilical vein, it keeps going, it branches into two portions. One portion go to the portal vein and one portion bypasses the liver. If they ask you what bypasses the liver, is the ductus. So it comes from the vein, so it's the ductus venosum, okay? Ductus venosum. Why venosum? It comes out from the vein. Ductus venosum. It's important during embryological period, and when we get born, it will transfer to something else that we'll say in a moment. So this collateral will move the blood from your umbilical vein up to your inferior vena cava. So what happened here? Here we had the oxygenated blood in the inferior vena cava, and there was minor mixing of the non-oxygenated and the oxygenated blood. And imagine with me, guys, this is really important actually. Let me even copy it here because it's super important to know this. I will make it in green. If the blood comes from here and it moves with force, okay? It moves with force and the speed. Will it move like this, then goes to the right ventricle and then to the pulmonary trunk? The answer is no. It will move from here and go directly through the Foramini Valley. Remember the Foramini Valley and how it's created and which fold was the movable one? Remember? The septum primum was the movable one. So yeah, we had a one-way valve. We said like right to left shunt during embryology. So yeah, that's its function. The blood will be moving here with force and directly goes to the left atrium. From the left atrium, it keeps going. It goes to the left ventricle, aorta, goes supply your brain and your upper extremities. Of course, I want you to know all of this is during embryology. And then keep going, and then it keeps going. It gets like a shunt from somewhere we'll speak about in a moment. And then it keeps going through your descending aorta. And after moving in your descending aorta, it goes to your internal iliac, common iliac, internal iliac. And this is important. From the internal iliac, you have two umbilical arteries. How many umbilical veins do you have? One. How many umbilical arteries do you have? Two. Why two? Because they come from the internal iliac artery. How many internal iliac artery do you have? Two. So that's why they are two. Okay. You are like, okay, but you missed one. So that was the first thing. Okay, I got it. So it comes from the umbilical veins and then it goes to supply the brain and all of that stuff. So I get it. And it comes from the inferior vena cava. All of the inferior vena cava system bypass through the Foramini Valley. Know that. Inferior vena cava, all of the blood go through Foramini Valley. But what about the superior vena cava? With the blood in the superior vena cava, I make it in blue now. No, actually, let me put red. With the blood in the superior vena cava go and pass through the Foramini Valley, the answer is no. Since this one moved directly with the gradient, it's like a river. This one will also move directly with the gradient. So the superior vena cava will directly drop the blood, where? To the right ventricle. Be like, no, wait a second, you are wrong, there's a valve here. The valve is not being made yet. It's embryology, guys. So no valve yet. So it will just be throwing down into the right ventricle. Okay, it's in the right ventricle. Where it will go next? It will keep going directly through the pulmonary artery. But there is a valve here. It's difficult. No valves yet. It's embryology. So the blood will move from this side and it will go through the pulmonary artery. Notice, artery, because it exits from the heart. So it will go through the pulmonary artery and then it will go to the lung. When it reaches the lung, it will find that the lung is full with the fluid. Yeah? Basically, amniotic fluid is filling your lung during embryology. We'll speak about that in respiratory, why it does that, to keep your alveoli big so they will not collapse on each other. But yeah, they will find the lung clogged, so they cannot pass blood inside of them, so the blood will go back. Yeah? When it will go back, the pulmonary artery pressure will go up. So it has to go somewhere where it can go. Well, here it was ductus venosus because it came out of a vein. Here we say it's ductus arteriosum because it's coming out of a artery. Vein, ductus venosum. Artery, ductus arteriosum. Okay, so that was ductus arteriosum. So all of the blood that comes from your brain backward passes through not the Foramini Valley, but the ductus arteriosus. Okay, so far so good. I hope it made sense so far. And now we read what's written in first aid. So both umbilical veins has PO2, which is like the saturation of oxygen, how much oxygen there is in it, 30 millimeters of mercury, and the saturation will be 80%. Guys, what is the normal saturation in our normal life as an adult? It's between 90% to 100%, but here it's only 80%. Well, that means that the baby is suffocating. No, not really. He's actually having really good amount of oxygen. How come? Well, the baby circulation has different type of blood. They have the fetal hemoglobin. The fetal hemoglobin is have such a high affinity to hemoglobin that it sucks all of the hemoglobin, even if the saturation of oxygen was low. I want you guys to remember about the oxygen dissociation curve. So that curve, in case of fetal hemoglobin, will be shifted to the left. We'll speak about this in respiratory. But what does that mean when it's shifted to the left? It means that the affinity of the hemoglobin is much more higher, okay? I will not go deep in it. We will explain it super deeply when we reach respiratory, but just keep in mind that that's in fetal hemoglobin, it shifts to the left. Okay, now back to CVS. So, yeah. What are the three important chants we have to learn? We just spoke about them. Blood entering fetus through the umbilical vein is conducted via the ductus venosum into the inferior vena cava. So we passed through the ductus venosum and then inferior vena cava, bypassing hepatic circulation. So this collateral, the ductus venosum, we said the main function is to bypass portal circulation. Why would I like to bypass portal circulation? Looks like a fun place to go. Well, yeah, but it has two problems. First of all, it might metabolize the nutrients and the hormones coming from mommy. Two, it has such a higher pressure. It has like increased pressure in that area, so it prefers to shunt to the other area instead. Okay, so the first shunt makes sense. What about the second shunt? So it is the Foramini Valley. Most of the highly oxygenated blood reaching the heart via the inferior vena cava is directed towards the Foramini Valley to the left atrium. Remember what I told you guys? Comes from the inferior vena cava and directly to the left atrium. It does not go to the right ventricle, does not go anywhere. It just go with the flow. Okay, what about the last one? Deoxygenated blood from the superior vena cava, basically the venous blood of the brain, passes, it just drops from up down. So it passes through the right atrium, right ventricle, main pulmonary artery, and then ductus arteriosus. After going to the ductus arteriosus, all of that blood from the both sides go to the descending aorta, and it chant. And why it chants? Why it goes through the ductus arteriosus and not to the lung? We just said that because of the pulmonary artery resistance, because of low O2 tension, and why we cannot pass here? Because the lungs are occluded. Why the lungs are occluded? Because they are full with amniotic fluid. Well, okay, the alveoli are full with amniotic fluid, not the vessels. Well, you are right, it's the alveoli full with amniotic fluid, but not the vessels. But take a look at this. If this is an alveole, and this is a vessel under it, okay? And we have a fluid inside of the alveole. If you fill the alveole so much fluid, this amniotic fluid, it will distend a little bit, don't you think? Have you seen what happens? You decrease the diameter of the vessels. If you do so, the diameter of the vessels is much more smaller. If the diameter of the vessel is much more smaller, what will happen to the resistance of the vessel? It will go up. That increases the pulmonary vascular resistance. I hope that makes sense. Okay, guys. So, they write pulmonary artery resistance increases, and we spoke about it. At birth, infant take his first breath. So there will be a decreased resistance in the pulmonary vasculature. Why? See all of that fluid? Baby is born. No more fluid. The pressure here will go back to normal. So also in the same time you will have more left atrial pressure versus the right atrial pressure. Okay, so remember the Foramini Valley flap? It will close. It will just shut. Okay, so the left atrial pressure versus the right atrial pressure will be increased, the ratio between the two. So the Foramini Valley will close, and now it becomes something called the Fossa of Valles, which I showed you the previous lesson, if you remember, guys. And I told you it's important, the Fossa of Valles, actually. Why it's important, guys? It's important to know the anatomical location of it, because they ask the following question about it. So if you take a look here at the Fossa of Valles here, it's located between the right and the left atrium. Yeah, and here we have what? The pulmonary veins. Do you remember, guys, where is the AFib ectopic foci located? I hope you are saying now it's near the pulmonary veins. If you take a look here, you can see the VFib ectopic foci. It originates near what? The pulmonary veins. If that is true, look at this procedure. It's called electroablation, which what we do, we basically insert a catheter from your veins towards your inferior vena cava. See the fossa of Valles? We burst it. We make a hole in it. And after making that hole, we reach what? The pulmonary veins. And here we ablate it. It's basically burn it, the ectopic foci. So the patient does not have atrial fibrillation anymore. I know it's cool, huh? So they will tell you about atrial fibrillation. They will show you an ECG of it, absence of the P wave, and they will ask you. They will tell you they inserted something through the veins, like a catheterization through the veins. Which structure should be penetrated in order to reach the ectopic foci? So to answer this question, you need to know perfect anatomy, and you need to know also the physiology. You need to know where the ectopic foci is located, which is near the pulmonary veins. Okay, good. Keep in mind that the flutter is different. A flutter is near the tricuspid valve. It's totally different. So atrial fibrillation near the pulmonary veins, flutter near the posterior leaflet of the tricuspid valve near the inferior vena cava. Okay. So there will be also increased O2 from oxygenation and decrease in the prostaglandins. Do you remember what these two things does? So why prostaglandins is decreased? Because normally what secretes it? The placenta. The placenta is out. So these two things, high oxygen, decrease of prostaglandins, lead to closure of the ductus arteriosus. Let's imagine that I want to keep it open. Two questions: why I would like to keep it open and how I would keep it open. So why I would like to keep it open. Let's imagine that someone, this is a different picture in blue, look down here, has a transposition of the great vessels. Okay, guys? So he has the pulmonary, he has the aorta going from his right heart, and he has the pulmonary artery going out from his left heart, which is abnormal. Yeah? This is the aorta. So this is abnormal. So immediately when the baby is born, if he does not have a shunt, he will die immediately. You have no chance. Goodbye, baby, he's dead. But if he has a ASD, VSD, or he has connection between these two, like what? PDA, he will live. He will live long enough to do the surgery on him to correct this. So if you diagnose transposition of the great vessel, you immediately need to keep that shunt open to give the child chance to live. Because if you don't keep it open, look what happens, guys. Here you have the aorta. It will leave from here and it will go to the venous system, and the venous system will go back here. So what the hell? There is blood moving in one circuit. It's not getting oxygenated at all. And on the other side, the pulmonary trunk will move the blood through the lung. It will get oxygenated, and it will go back to the through the pulmonary vein to the left heart, and it will not go to the system. So it's too close shunt. If you do not, too close system. If you do not have a shunt, the baby will die. So you need to keep that BDA open. BDA is abbreviation for beta ductus arteriosus. How can I keep it open? Remember that if prostaglandin is secreted from the placenta, we need to keep it secreting. How? We give it as a medication. Okay, so we keep giving prostaglandins. Well, let's imagine that the baby is normal, but he has this BDA and we would like to close it. How do we close it? We give NSAIDs. They inhibit the prostaglandins. Which NSAID exactly? Indomethacin. Ibuprofen also work, but they prefer indomethacin because it's stronger actually. Okay, indomethacin helps closes the beta ductus arteriosus. It's an NSAID as we said, and it becomes the ligamentum arteriosus, which is the remnant of the ductus arteriosus. Okay, why they mentioned for us the ligament arteriosum? Did they just put it there by mistake? Not really. It's super important. Why ligamentum arteriosum is super important? Okay, guys, let's imagine that someone is driving a car, okay? And after he's driving the car really quick, he get in a car accident, so he hit something. So he will have acceleration, deceleration injury, yeah? So the acceleration, deceleration injury will lead to what? You have one portion of your aorta that is connected by something called the isthmus, okay? That isthmus, where it is, yeah, see this isthmus? It's here. Here we have the ligament connected, okay guys? So if someone gets in a car accident, he has an acceleration deceleration injury that leads to the tear of the aorta. Why? Because the ligament is connected here. Which ligament? Ligamentum arteriosum, which is a remnant of what? BDA. So I can give you a question about a tear of the aorta, clinical vignette, and you have, and I can ask you what embryological origin does the structure that was connected to the isthmus come from? And you have to tell me BDA. So yeah, the question can be quite interesting on it. See, all of the injuries of the aorta happens here. Why? Because of the ligamentum arteriosum. See the ligamentum arteriosum, guys? Good. So, yeah, so exactly right here. And they do give this picture a lot on the exam, guys. Please know that the ligamentum arteriosum connects to this area. Not this area, not this area, it's this area, which is distal to what? It's distal to the left subclavian artery, okay? Good. So, the prostaglandins that are effective, E1 and E2, keep BDA open. Okay, not bad mnemonic. So, guys, after embryology, you need to know why and what each ligament function. So, the ductus arteriosum. Ligamentum arteriosum, after born, it becomes ligamentum arteriosum. And you need to know that it goes near the recurrent laryngeal artery. So what is this recurrent laryngeal artery? Look at this picture. So the laryngeal artery is a branch of vagus nerve that goes from the left, where? From the left it goes around the aorta, near what? Correct, the ligamentum arteriosus. And from the right, it's totally different area. It goes from the, around what? The brachiocephalic artery. So left, around the aorta, right, brachiocephalic artery. Why it's important? Well, let's imagine someone got a tear of his aorta, like we just said. So this guy will be injured. If you injure your recurrent laryngeal artery, what you will have? The thing that I'm having right now, hoarseness. So your sound will become like your sound will become weird. Okay, important question. This is a step 2 question, but I will tell you it. What happens if you destroy both of these nerves? Like you destroy the right recurrent and the left recurrent. You become mute. You cannot, well, you will have zero voice. You cannot speak anymore. Keep in mind that they like to mention someone who had a thyroid surgery, and after that he have hoarseness. They ask you what was damaged. Correct. Recurrent laryngeal nerve. Excellent. Someone have aortic aneurysm. What was damaged? Hoarseness. Recurrent laryngeal nerve. You can see the ligamentum arteriosum relationship with what? Recurrent laryngeal nerve. Yeah, let me just send you this picture, guys. Okay, let's go here. We have ductus venoso, ligamentum venosum. It becomes ligamentum venosum, not super high yield, but you have to know that this ductus venosum that can make something called like a ligament inside of your abdomen. It's not super high yield, but what is super high yield is this guy, Foramini Valley, that becomes Fossa of Valles. That what have passed through it? The catheter that was used to ablate what? The ectopic foci. The ectopic foci of what? The VFib. How does the VFib look like? I'm sorry, not VFib, AFib, atrial fibrillation. Atrial fibrillation, ECG. How does the atrial fibrillation look like in an ECG? Well, that's a flutter, that's a fibrillation. So when you look at the fibrillation, you are like, okay, yeah, so it's the B wave does not exist. That's a AFib, okay? You look at the, always start from the second lead. You look at the P wave, it does not exist. So that's an AFib. Good. Okay, so the next question, next one is about the allantois. So the allantois, maybe you remember I just showed you a section of the umbilical cord, and inside of it there was 2 umbilical arteries, 1 umbilical vein. And there was this allantois. I told you I will tell you about it later. It's actually more in reproductive, but I can tell you a little bit about it now. So the allantois give origin to something called the auracus. I remember the first time I saw this word, the auracus, I really could not understand what that is. Apparently, I understood it in a way that I never was able to forget it. So, the auracus is actually not for a human, guys. It's for chicken. Okay, yeah, for chicken, not for us. But what is that? So basically, the chicken, from the same hole, it can poop, it can make an egg, and it can have sexual intercourse. Okay? From the same hole, like from the same opening. During embryology, we have like this auracus, which is hole that is used for multiple stuff. Okay? So that hole have connection with your being system in the same time in your nutritional system. Okay? So your being system, it's your bladder, and your nutritional system is like the umbilical arteries and veins and all of this stuff. So the allantois is the median umbilical ligament, will be after birth. I will explain exactly what that is. But I just want you to know that the auracus is a part of the allantoic duct. This duct is between the bladder and the umbilicus. Let me tell you a little bit about this median and medial umbilical ligaments. They are super important. You have to be comfortable of looking at this picture. A lot of students cannot comprehend what does this picture mean. So let me explain for you first of all what does this picture mean, and then show you what is in it. Imagine you have a human being in front of you and he's like this. You are looking at him from the side, okay? That's his head. And that's his nose here, okay? His legs. And you want to look at his peritoneum. So let's imagine you take a scalpel and you cut him like this. Okay, now you took this portion that you just cut and you put it here. Okay, now this is the outside, this is the blue portion, basically this is the outside, and you are looking at the abdomen from here, from this side. What you are going to see, you are going to see this. Okay guys, so what is that? It's a lot of structure. Yes, it's a lot of structure that you have to know most of them. Okay, so let me just, and why it's important, see this? This is hopefully one of you in the laparoscopy lab one day will be able to know what is this structure. What is this structure? Should he cut this or not? If he cut this, will the patient bleed as hell and sue him? Probably. So yeah, you need to know this structure. So, I just want a good picture. Yes, this one is perfect. Okay, so let's take a look here. So we have 5 ligaments you have to know, guys. This is one in the middle. Let me make color red. The one in the middle, the actual middle, we call it median. Okay, median with IN in the end. Median. So IN, median. Okay, so you only have one median. Only one median. What about the medial with an L in the ending? You have 2 of them. I imagine like 2L, so 2 laterals. So you have 2 laterals, okay? And there is also another 2. If there is a median umbilical ligament, there is a lateral umbilical ligament. So each one of these guys originated from something. So let's see what they originated from. They can show you a picture of one of these ligaments, give you an arrow, and tell you what that originated from. So the median one originated from the allantois. And remember, you only have one allantois in your body. Yes, the one that was connected to the bladder. So you only have one. That's why you have only one median ligament. While the median umbilical ligaments with an S, it's 2 of them. They come from the umbilical arteries. And how many umbilical arteries you had? Correct, 2. The next one is the umbilical vein. So the umbilical vein, this guy, remember? It makes you something called the round ligament, also called teres. Teres in Latin means round. Okay, guys? So ligamentum teres hepatis. So it's round ligament. It's contained in the falciform ligament. So what is the falciform ligament? If this is a liver, if this is a liver here, and there is a ligament in between the 2 lobes, that ligament we call the falciform ligament. And that ligament, the falciform ligament, has a ligament coming out of it like this. Okay? And that ligament coming out of it, we call it the round ligament of the liver. And it connects to what? To the abdominal wall. So you can see it exactly here. So you can, hope you can appreciate. I'm sorry, the liver was wrong to be drawn here, but take a look at this. See this? This is the round ligament. And the round ligament will keep going until it reaches what? Until it reaches the falciform ligament, which is located between what and what? Correct. The 2 lobes of the liver. Excellent job, guys. So, please be careful. Lateral to the median ligament, there is vessels here. It's called the hypogastric vessels. This will be super important, and we will be back to this page to tell you that direct and indirect hernia originate from medial and lateral sides according to their type. And that will help you answer a lot of questions, and that will help you in the real life when you be palpating the pulsation of this artery to be able to tell if this hernia is direct or indirect. Okay, guys, I know some of you want to leave. So the ones who want to leave can leave, and the lecture will be recorded and uploaded on YouTube, but this time it will be on private. And I will send you links for those who leave. Those who can continue, please continue. I want to just finish this page and the next page. Okay, so the last structure I want you to know is the notochord. Do you remember what was the function of the notochord we said the previous lecture? The notochord used to secrete a factor called the sonic hedgehog factor. And that led to what? That led to the formation of the neuronal tube. Please know that the notochord does not come from ectoderm. It actually comes from mesoderm, not ectoderm. But it helps in the differentiation of the ectoderm. So yeah, the notochord in the end gives origin to what? The nucleus bulbosus. What is the nucleus bulbosus? Nucleus bulbosus is the middle portion of your vertebral disc, this one. So if they ask you, the portion that is herniated during a disc hernia comes from what? The answer will be the notochord. If they ask you the exact same thing and they tell you the embryological structure secretes what? The correct answer will be sonic hedgehog. Okay, good, guys. So that page is done. So we are done with the embryology of the heart. That was not that painful, actually. It was not that bad. Okay. So now the heart anatomy. You're like, wait a second, only one page about heart anatomy? Well, yeah, and it's easier than you think, especially for the USMLE. They don't ask too much. They are not your medical school. They will not ask you too much about it. They only want you to know the clinically related pathologies. Other than that, they don't really care about it. So let me speak a little bit with you about the heart. So really quick, how many chambers of your heart do you have? Excellent, 4 chambers. This is important. You have to know the orientation of your heart. Which chamber is the anterior-most chamber? Which chamber is the posterior-most chamber? I told you about this yesterday. So the anterior-most chamber is always your right ventricle, okay? Right ventricle. Behind it exactly is your left ventricle. You are like, wait. You are wrong. I know for sure that the left ventricle, I can palpate its apical impulse. Excellent. So only at the apex, the left ventricle will be there. The rest, it will be right ventricle. So this can be asked in your exam. If I tell you a patient had a sternectomy, which chamber of the heart is highly susceptible to get injured? Your answer need to be right ventricle. If I ask you a question, during a transesophageal echo, like you went through the esophagus and you did an echo of the heart, so you are looking at the heart from the posterior side. During a transesophageal echo, which chamber of your heart are you looking at? Your answer has to be left atrium. So right ventricle is the anterior-most chamber, left atrium is the posterior-most chamber. So why we do actually transesophageal echo? Because you want to visualize the left atrium good. Is it visible with the transthoracic echo? Yes. But the transesophageal is much more specific and much more sensitive actually. What we are trying to look inside of the left atrium? Well, myxomas can be inside of the left atrium, which is tumor of the heart. What else? It can be, in case of atrial fibrillation, we need to check it using transesophageal echo. We need to check for formation of thrombosis inside of the left atrium because in case of they are present, we want to prevent an emboli and we need to give anticoagulant. So that's important. Okay, so let's take a look here. They write, left atrium is the most posterior part of the heart. You can see it here. Enlargement of the left atrium, okay. One example is mitral stenosis can compress the structure behind the left atrium. Which structure is behind the left atrium? I just told you the transesophageal echo we do to visualize the left atrium. So the esophagus is behind the left atrium. So that will lead to compression of the esophagus. So in really severe cases of mitral stenosis, the patient can complain of dysphagia. And also, do you remember that nerve that goes around the aorta? Excellent. The left recurrent laryngeal nerve. And it goes near which ligament? Excellent. Ligamentum arteriosum. So what is this recurrent laryngeal nerve? I showed you it. It was a branch of the vagus nerve. And if you injure one of them, you get hoarseness. If you injure 2 of them, you become mute. You cannot speak anymore. And we call that Ortner syndrome, the hoarseness, due to enlargement of the left atrium. Due to mitral stenosis. Mitral stenosis with enlargement of the left atrium can also precipitate to atrial fibrillation. Good. Also to pulmonary edema because the blood will be moving back. So the right ventricle is the most anterior chamber of the heart and is most commonly injured by a trauma. They love to ask you about someone getting stabbed in the chest and they ask you which chamber it is. It's always the right ventricle except if you hit the apex. If it's at the apex, it will be the left ventricle. Where is the apex located? 5, you can write it down, 5th intercostal space, 2.5 centimeter left to the midclavicular line. That's it. The next one. Okay, so we are done with the orientation of the heart. Now let's speak about the pericardium. The pericardium consists of 3 layers. So from out to in, we have fibrinous pericardium, which is the thickest between all of them. And we have the parietal layer of the serous pericardium, which is actually attached to the fibrinous pericardium. I used to imagine these together, and this is alone. And the visceral layer of the serous pericardium. So actually there is a cavity between which 2 layers? I told you these 2 are kind of like one. Yeah? So the cavity needs to be between the parietal and the visceral layer of the serous pericardium. So the pericardial cavity lays between the parietal and the visceral layers. And you have to know the innervation of the pericardium. They keep tricking students by telling them vagos. Vagos, correct, go near the pericardium, but it does not supply it. The innervation of the pericardium is from the phrenic nerve. And you have to know where the phrenic nerve comes from. It comes from your cervical segments of your spinal cord, which are C3, C4, C5. If you forget it, there is this mnemonic that says C3, C4, C5, keep the diaphragm alive. Okay? Phrenic, it means something related to the diaphragm. Good. Pericarditis can cause referred pain to the neck, arms, and both shoulders, often one. Why it can lead to referred pain? Because of the phrenic nerve. Phrenic nerve lead to referred pain. If you remember, in case of cholecystitis, there is referred pain to the right shoulder. In case of gastric pathologies, there is referred pain to the left shoulder because of the phrenic nerve. In case of pericarditis, there is referred pain to the neck and the shoulders because of the phrenic nerve as well. Okay, so the last thing for today will be the coronary blood supplies. I just need to make a quick bowl. 1 second, guys. Please participate in it. Should we do Q's after? Please answer it quickly until I finish with that. Okay, so coronary blood supply. So the left anterior descending artery and its branches. So we have like the maker of the widows, you know. They call it the maker of the widows. Why? Because it kills so many people. What is that? The left anterior descending artery. Left anterior descending artery, well, where does it come from? Oh, okay, let's see. Excellent, good. So the left anterior descending artery. It comes from what? So it comes out from your left coronary artery. So your left coronary artery is here. Where does all of the coronary artery exit from? Guys, do you remember this picture I keep annoying you with? So here is your left atrium, here is your left ventricle, here is your aorta, and here you have, what is this? This is your aortic valve. So near the aortic valve, just near it, here, exactly here, you have what? The coronary artery exit. So imagine with me, guys. During systole, what happens to the aortic valve? It opens. If it opens, it will block what? The coronary artery. You are like, wait a second, so the coronary artery will not be supplied during the contraction of the heart and during systole? Exactly. So during systole, there is no blood flow through the coronary artery. So the question they keep asking, when is the coronary artery of the heart are supplied? The answer is during diastole, when the valve is closed. So when you close the valve, the artery will be open and the blood will pass through it. And the coronary arteries are only supplied during diastole. Hope it makes sense. Okay. Okay, so they write left anterior descending artery, which comes from the left coronary artery, supplies the anterior 2/3 of the interventricular septum. And remember the interventricular septum? Good. And also it supplies something called the anterolateral papillary muscle. You are like, what is this papillary muscle? So first of all, what is the word this papillary mean? Papillary means like something that fingery like. It looks like a finger. So take a look here. This papillary muscle. It looks like a finger. Finger. Okay? And also some resources can tell you that it looks like a nipple. But I prefer finger. So here we go. So papillary muscle. And it has this chorda tendineae, and these chorda tendineae are attached to what? The muscles. We have two muscles. We have the anterior one and the posterior one. Each one of them is supplied by different what? Different blood supply. So we have the anterolateral papillary muscle is supplied by what? The LAD. The posterior one is supplied by what? The PDA. It's totally different. Okay, so papillary muscle and the anterior surface of the left ventricle, which is the most commonly occluded. That's why they call it the maker of the widow. So if we take a look at the left ventricle only, so I'm drawing now only the left ventricle, guys. This is the left ventricle. And in blue, the right ventricle. So if we speak about the LAD, they said, let me make it in green. They said it supplies this area, the anterior 2/3 of the interventricular septum. Okay, what else? The anterior wall, they said. So anterior 2/3 of interventricular septum, the papillary muscle, the anterior surface of the left ventricle as well. See, all of this, guys, all of this is supplied by him. So what is left? I mean, come on, it's supplying everything. Well, you have your right one is not supplied and the posterior 1/3 is not supplied yet. Okay, so what supplies it? We have another artery called the PDA, posterior descending artery. It supplies your AV node. What is your AV node? This is in the conduction system of the heart. That will be one of our main topics because, guys, before we finish this course, every single one of you, and not before finishing the course, before finishing this month, like that you're already in, before finishing this month, everyone and every single one of you must master ECG. He must like get any ECG in front of him and be able to read it comfortably. So the PDA supplies the AV node. We'll take a lot of time to know where it is, what it does, everything about it. And it's only the PDA supplies it depending on the dominance. So what does dominance mean? Well, look, guys. Sometimes your posterior descending artery comes from your right coronary artery, okay? Sometimes it comes from the left circumflex artery, which is this one, which comes from the left coronary artery. Sometimes it comes from both. So look, guys, look at this one. Give me a pen. Okay, so you can see here we have the PDA, and it's originating from what? From the right coronary artery. So if we take a look here, come here, so, good. So if we speak about the left circumflex and the patient was left predominant, the PDA will come like this, okay? This will be the PDA. In this case, he's right predominant, which is the most common. See, it's coming from what? The right coronary artery. What does it mean if he was co-dominant? It means something like this. The vessel comes from here and also from here, and they attach here and they go down. What is the best scenario? Well, actually this one, because if one gets occluded, you still have blood from the other one. So it's the best of the best, but it's rare. Only like 5% of the people have it. Yeah, 7%. So the right dominant circulation, 85% of the people, the PDA arises from the right coronary artery. Left dominant, it comes from the left circumflex. Co-dominant, from both. Oh, and here they write, coronary blood flow peaks during diastole. Remember what I told you? Keep that in mind. So, the PDA, the AV node supplement depends on the dominant. So if it was right dominant, it comes from the right coronary artery. If it was left dominant, it comes from the left circumflex, the AV node supplement. What about the SA node? The SA node, it doesn't matter which right, left, co-dominant, it doesn't matter. It's always coming from the right coronary artery. Make a note about this. Okay, the PDA also supplies the posterior 1/3 of the interventricular septum. It also supplies the posterior 2/3 of the ventricles and the posterior medial muscle. So back to this here. Oh, okay. So you remember this picture I made here? So the PDA, I'll make in yellow, supplies the rest basically. Yeah? 2/3, the posterior walls of these, so it supplies everything. What about the right coronary artery? It supplies everything in the right ventricle, guys. And all of the walls of the right ventricle is supplied by what? The right coronary artery. So, posterior 1/3 of the intraventricular septum, posterior 2/3 of the walls of the ventriculi, and the posterior medial papillary muscle. These papillary muscles are super important because you can imagine, in case of infarction, like occlusion of one of these vessels, you can have destruction of one of these papillary muscles, which will lead to regurgitation of what? Of the mitral valve, because these muscles are connected to which valve? The mitral valve. Excellent job. Okay, so the right coronary artery supplies the SA node, always. Okay, guys, it's always. It does not care about the dominance. So yeah, blood supply independent of the dominance. Infarct may cause nodal dysfunction. Of what? The right coronary artery, the infarct. So in case of infarct, the right coronary artery, you can have an SA node dysfunction, which can lead to bradycardia, okay, or heart block. The right acute marginal artery supplies the right ventricle. So there is something called the marginal arteries, guys. And that marginal artery originated from what? So they write the following. Right marginal supplies the right ventricle. So the marginal artery that comes from the right coronary artery, where it is? Yeah, here it is. This one, AMA. It supplies your right ventricle. And that's everything about the heart supplement. We will be going about this topic again when we discuss the different ischemias and the ECG differences. And guys, when we have the ECG class, I believe it will be like next week. I want everybody to be present. I will be explaining that topic twice because, guys, you have to be able to look at ECG cases and be able to be comfortable with them. I will show you about each pathology at least 1 to 2 ECGs, and we'll be retesting you about them recurrently until you master ECG, because on the real exam you are going to get 3-4 ECGs and just the 3 points if you know how to read them comfortably. Okay, now with the questions. So I will do the following. I will put this screen here and I will open Telegram here. All of you guys are anonymous. Nobody can, like, if anybody writes anything now, all of you are named the same and nobody can tell who you are. So you can answer comfortably without being afraid of security and like someone will laugh at you. So yeah, all good. So let's read the first question together. A 5-day-old boy is brought to the emergency department by his mother because of a 2-day history of difficulty feeding and multiple episodes of his lip turning blue. So he has some form of cyanosis, guys. Yeah? He's 5-day-old and he already has cyanosis, early cyanosis type of thing. So he was born at home via spontaneous vaginal delivery and an Apgar score of blah 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 blah, not important. Physical examination show you grunting and moderate intercostal and subcostal retraction. Okay, so he's in respiratory distress, he has early cyanosis, and on echocardiography, it shows a single vessel exiting from his heart. He has a single vessel exiting from his heart. So, which of the following is the most likely underlying cause of the patient condition? So guys, there is a single vessel exiting from his heart. So he does not have like an aorta and the pulmonary trunk. No, he has one big vessel that passing both the aorta and the pulmonary trunk. Now the question says, by the way guys, be careful of the question because sometimes it means something totally different. The question says, which of the following is the most likely underlying cause of the patient condition? Is it, let's start from A. Is it failure of neural cross cells migration? Well, first of all, which pathology do you guys think it is? One vessels exiting the heart. Can someone write which pathology he thinks it is? Come on, guys. One vessel exiting from the heart that contains both the pulmonary artery and the aorta, that supplies both of them. Okay, excellent. The one who said truncus arteriosus, excellent job. Good. Good. The truncus arteriosus, exactly. So, the truncus arteriosus, it's like one vessel giving origin for 2. So in that one, in truncus arteriosus, by the way, guys, it's okay if you got it incorrect because we did not even explain this topic yet. I could not find like a direct embryology question, so I had to get a second, like this was difficult question actually, and you had to know have a knowledge of like cyanotic heart diseases, which we did not study yet, but still. with the knowledge you have already, you are able to solve them. That means good job, guys. So, okay. Do you remember where does Truncus arteriosus originate from? Like that structure himself. Maybe you remember. Is it due to failure of neural crust? Excellent. Come on. Yes, exactly. It's due to failure of neural crust cells migration. If that does not occur, the patient will be basically will not form a truncus arteriosus, truncus arteriosus normally. Wow, that was a question from between the lines, guys. It's not an easy one at all, I have to say. Like when I first saw it, it took me a moment until I got it, but here it is. Okay, so it's one of these conotruncal abnormalities. It's persistent truncus arteriosus, and you can see neural crust and endocardial cell migration. Excellent job for the one who answered it, which can you please zoom on the word? Okay, yes, of course I can. Just a second. I hope it's better. I cannot. Yeah, I hope it's better like this. Okay, guys. So the next one will be as follows. Shortly after delivery, a female newborn developed a bluish discoloration of her lips. Again, it is what? This is early cyanotic heart disease. Lips, finger, toes, all of them are blue. She was born at term to a 38-year-old prima gravidia woman. Pregnancy was complicated with diabetes mellitus. Room air shows oxygen saturation of 81%. And this is where it is important. Immediate bifurcation of the vessel arising from the left ventricle. Okay. So the vessel, there is immediate bifurcation of vessels arising from the left ventricle. The vessel emerging from the right ventricle give out the coronary artery. This is abnormal, guys. From the left ventricle, you should not have bifurcation. The pulmonary artery does that. And from the right ventricle, they tell you that the vessel they give you the coronary artery. That's the aorta give the coronary artery, not the pulmonary trunk. So here there is something messed up. Head and neck vessels from the right heart, that's wrong. So this pathology, you have what? What is the pathology here, guys? You have aorta originating from the right ventricle and pulmonary trunk originating from the left ventricle. Excellent. It's a transposition of the great vessels. Excellent. It's due to spiraling of the aortopulmonary septums. Excellent. It's the egg on the string. Good job, guys. Good job, good job, good job. Okay, one more? Right, yes or no? Okay, good. Yes, yes. So let's do one more. So that was the first question. Next question. So, okay, some pictures for you guys. So the next question is kind of difficult. So, yeah, it's not the easiest one, but let's see. By the way, don't look too deeply. I have it enlarged here, so don't worry about it too much. But we will see it after reading. A 56-year-old man is brought to the emergency department 25 minutes after the sudden onset of severe pain in the middle of his chest. He feels severe pain in the middle of his chest. He describes the pain as tearing in quality. It radiates to his jaw, and he has hypertension. Okay. So he has smoked one pack of cigarettes daily for the past 25 years. He takes an Alabril and his blood pressure is ridiculous. But this is important. Right hand blood pressure is high, but the left hand blood pressure is different. So right to left is different. So there is disproportion between the right and the left heart blood pressures. I did not teach you this yet, but oh my God, yes, you are right, the one who wrote dissection. A CT scan of the chest is shown. A structure that is damaged in the patient is a derivative of which of the following? So first of all, guys, let's just, yeah, the crescent, exactly. But what is this overall? What is this? this, it's not an aneurysm, it's a dissection. But I mean, which vessel? Yes, it's a dissection of the aorta. Good. And so see this pseudolumen? There is a fake lumen here. It's like a vessel inside of a vessel, yeah? So what happened here is like the blood has moved under the endothelium of the aorta, and it led to making of a fake, basically a fake lumen, a fake opening. And that fake lumen basically led to formation of two vessels inside of one vessel. So when you see that, that's the aorta. So the question is asking, the structure that is damaged, which is the aorta in this patient, is a derivative of which of the following? So the aorta is a derivative of which of the following? Excellent job, guys. It's truncus arteriosus. Remember we said about the truncus arteriosus gives origin to both the aorta and the pulmonary trunk? Excellent. What about the right common cardinal vein? It gives origin to what? I hope someone will answer that one. Excellent, excellent. Good, good, good. It's superior vena cava. Yep. Great job, guys. Great job. So you can see this picture. I just want you to know a few stuff. So this is the ascending aorta, but what is it? This one. Nobody write vena cava. It's wrong about this one. What do you think, guys? Count to 5. Excellent, descending aorta. Yes, it's descending aorta. So you're like, wait a second, this is ascending and this is descending. Yep. So it goes from here and it actually whoop, loops and goes down. Yeah, exactly, the arch. So it arches and goes down. So what is this? Here. Yes, it's the pulmonary trunk. Excellent. Good job, guys. Okay, one more question. Good. Let's do one more question. So we have a 3-month-old boy is brought to the physician by his mother. Because of poor weight, she also reports that he has a dusky blue discoloration in his skin during feeding and when crying. So we call these the teeth spills. Yeah, teeth spills we call them. Like he becomes bluish only during exertion and stress. On examination, there is a harsh systolic murmur heard over the left upper sternal border. Systolic murmur, left upper sternal border. Ooh, sounds weird to know, so let's do the 3 steps way of knowing any murmur in the word. So step number 1. We do this straight line. We put S1 on it. And S2. Between S1 and S2 is systole. Between S2 and S1 is diastole. Yeah, we know that. We have to memorize only mitral stenosis. So the similar valve in the right heart, the another AV valve will be the also stenosis. So the tricuspid will be also diastolic murmur. Okay, what 2 valves are left? Aortic and pulmonic. So both of these will be regurgitant murmur. So here we do absolutely the opposite. So here it will be pulmonic stenosis, aortic stenosis, mitral stenosis, tricuspid stenosis. So let's go back to the question. The question says systolic. So see all of these guys, we roll them out. It cannot be any of these. The second clue they give us, left upper sternal border. What is the only murmur that is heard at the left upper sternal border, guys? Pulmonic, excellent. So it's the pulmonic area. Maybe you remember, it comes like the picture on first aid. The A, B, T, and so it's the aortic, pulmonic, tricuspid, and mitral, yeah? So it's the P for the second intercostal space, on the what? It will be on the left. So, and systolic merma. So it's pulmonic area, systolic merma, pulmonic area. So it cannot be aortic, cannot be this, cannot be this. It's pulmonic stenosis. Patient has TT spells and pulmonic stenosis. What do you think? Which pathology do you think he has, guys? Pulmonic stenosis. And he also has, except of the pulmonic stenosis, he has the TT spills and his heart looks like a shoe. Exactly. Yes, tetralogy of Fallot. Excellent, everybody. Okay, and tetralogy of Fallot, they're right. Which of the following is the most likely cause of his symptoms? So what do you think, guys? Which one of these is associated with tetralogy of Fallot? I see something. More answers. Come on. Well, a persistent connection between the aorta and the pulmonic artery, that's a BDA. This patient has tetralogy of Fallot, not a BDA. Tetralogy of Fallot, remember what it has. The constellation of symptoms, which were pulmonic stenosis. It has also VSD, hypertrophy of the right ventricle, and an overreading aorta. So the correct answer here is actually correct. It's D. It's right ventricular outflow tract obstruction due to the pulmonic stenosis. Anyway, guys, that was the last question for today. Thank you so much for attending today's lecture. We will stay in touch on the Telegram group to decide when will be the... He wants one more question, okay? Got you, man. I just hope that... Oh, okay. Here we go. That's the last one in the file. Okay, so a 30... is it visible for you guys? Can you see the writing? Okay, good. A 38-year-old woman, gravida 2. When you read in the question gravida 2, it means she was pregnant twice. Bara 1, she delivered once. So she was pregnant twice, delivered once. And she has at 24 weeks of gestation. Remember, normal pregnancy is 40 weeks. She comes to the physician for a routine prenatal evaluation. She has no history of major medical illness, and she takes no medication. Awesome. Fetal ultrasonography shows a heart defect resulting from an abnormal development of the endocardial cushion. Okay. So the defect is most likely to result in which of the following? So endocardial cushion are screwed. Endocardial cushion makes you what? Man, you are fast. And right, not only fast. So yeah, it's atrioventricular septal defects, because you remember they helped us to make the they helped us to make the intraventricular septums. They also helped us to make the intraventricular septums. Which portion? Was it the membranous or the muscular? Write me, please. The endocardial cushion help in making the membranous or the muscular. Excellent, the membranous, the thinner part. And what about if we speak the endocardial cushion? They bind to the septum primum or the septum secundum? They bind to the septum primum. Septum primum, guys. If you remember the septum primum, it was the mobile portion, and it goes like this. Here it is. See? But I hope someone answer it actually. Well, it actually, yes, it's septum primum, but after sometimes you know that the septum secundum divides as well. So yeah, I did not explain you this, my mistake. But actually it's both of them. So both of you are right, guys. Okay, the last thing, last last minor question I have for you, not a question actually, it's an explanation. Guys, if you look at a cross section of an umbilical artery, and you know that inside of it you should have 2 arteries and 1 vein, and instead you only see 2 vessels, 1 artery and 1 vein. This patient has a trisomy. What is a trisomy? It could be Down syndrome, okay? Please know this fact because they do ask it. So again, cross section of umbilical artery, and when you look inside of it, it could be Down syndrome, exactly. Okay guys, so that's it for today. On this Telegram group, we will schedule the next session. I told you we will be having like 3 to 5 classes. Initially in the first week, I'm thinking like to have 4 at least, 4 or 5 classes like from the first week. So probably the next class will be tomorrow or the day after tomorrow. We will decide by writing on this group. Okay guys, have a nice day. Anybody has any question? Where are we going to find this lesson? Well, okay, I'm recording, so I'm going to save it, and after I save it, I edit it, so I delete all of the breaks and stuff like that. After that, I will upload it on YouTube on a private, and yes, I can send you the photo. I upload it on a private, and then I will give you the link, and you will go to the link, and I will give you like a code to put there. Yes. Can you please? Yes, of course I can send you the whole file and with the answers. Okay, let's just